Good afternoon. Before we are still 1 minute ahead, and before we start this afternoon sessions, and in order to be economical in terms of the use of my minutes, I'd like to thank for this possibility to be here today, to thank the organizers and especially Carlos Dias for this organization and for this invitation. It's a pleasure to take part in something that has such a long tradition and is part of our scientific and clinical construction here in Porto. And it's also something that is not usual, that we have the biggest hospitals and groups from the biggest hospitals and medical schools in Porto engaged in the same organization, with the same or looking for the same outcomes and trying to construct something together. So I have to be happy to take part in this not only tradition, but also this approach that is not, as I was telling you, frequent in our country, and I think it's not only in our country. The possibility to introduce João Faro Viana is also a great pleasure, because he is a medical doctor, a clinical pathologist that has been engaged in especially in immunology, and he is one of our best and is one of the leaders of the area in Portugal. He heads the clinical pathology department in the, I think it's the first time I say it in English, West Lisbon University Hospital Center, and he is someone that is very well prepared in the area of immunology. Of course, he is also at this time the president of the Portuguese Society for Laboratory Medicine, and he's someone that has been engaged not only around immunology but around the clinical pathology as a whole. Here he is going, or this afternoon he's going to address something or a theme that is immunological in terms of, we are speaking about antibodies, but also very actual. He has been working in the area of COVID-19, or more scientifically in terms of SARS-CoV-2 since the beginning of the process, or we could say before we had the first case in Portugal. And he has been especially interested in the studies around the production, the monitoring, and our capacity to look to the serology of SARS-CoV-2. So I would like to introduce João Faro Viana, and mostly I have to say that it's a pleasure because he is a dear friend, someone that I enjoy a lot being with. So my conflict of interest is very clear. I like him a lot, so do not or discount some of my appreciation, because as I tell you, I enjoy a lot having this possibility to introduce João Faro Viana. So SARS-CoV-2 antibodies highlights João Faro Viana, the next minutes. Thank you.
Sorry. Good afternoon, everybody. Thank you, Tiago, for your kind words, and exaggerated as usual. Thank you, Carlos, for the invitation to be here once again, and congratulations, both Carlos, for the organization, of course. Some of you might be asking, why the hell is this guy going to talk about COVID antibodies in an autoimmunity meeting? Well, I must say that the main reason is because I can, and I can because Carlos let me choose the theme and I'm getting too old to learn new things. So I prefer to speak of things that I have some sort of experience about. So, but also, I think that some of the thoughts that I will share with you today can also be applied to the autoimmunity field, because there's some of the problems with antibodies, infectious antibodies, are also shared by autoantibodies, of course. So as you all know, okay, as you all know, SARS-CoV-2 is an enveloped RNA virus. It has several proteins, structural proteins that can be immunogenic. I will be highlighting only two. One is the nucleocapsid, that is the protein that is associated with the RNA, and the other is the spike protein, the protein that is responsible for the virus entry into the cells. Actually, sorry, problem here. Okay, actually, the spike protein is composed of two subunits, the S1 and S2. The S1 subunit is the one that is responsible for the recognition of the specific receptor on the human cells, which is the ACE2 receptor, through a smaller region called the RBD, or receptor binding domain. But also the S2 subunit is very important because it is responsible for the fusion between the viral membrane and the host membrane. So it's a very important component of the infectiousness of the virus. This is a small scheme of the viral cycle. I'm not going into details. I'm just showing this because to highlight the importance of the initial fight of the cell against the virus. As soon as the virus enters the cell, it is recognized as a foreign substance, and the cell starts fighting it by secreting antiviral substances, for example, type 1 interferons. And this interference will recruit other players from the innate immune response that will in turn trigger the adaptive immune response and will eventually end up on the production of antibodies. So why am I showing you this? I'm showing this because antibodies are, of course, very important, but we must not forget all the other players that sometimes are underrated. For example, in this study here with more than 2,000 intensive care unit patients, an association was found between critical illness and some genes of the innate immune response, like type 1 interference or mediators of inflammation. So the other players are very important. We should never forget them, but we'll just we'll just talk about antibodies because, of course, the adaptive immune response is our hope. The adaptive immune response is the one that will be responsible for the protection that we hope it will be long-lasting, either post-infection or preferably, of course, post-vaccination. Of course, the immune response against the infection is not the same as the immune response to vaccination. For example, the current vaccines are intradermal or intramuscular, are administered this way, so they do not generate mucosal immunity, which is something that the natural infection can generate. We should not forget this. And so actually at this time, there are some phase 1. I think that's also some phase 2 and phase 3 trials in these types of vaccination. Another difference that we get between infection immunity and vaccination is that infection, the response to infection is much more heterogeneous because it seems to be dependent on the viral load and also on the severity of disease. Some say also that the vaccine response is stronger on an average level, it's Atlas. So some words about vaccine platforms. We are using 4 vaccine platforms at this moment for SARS-CoV. One is the whole virus. Actually, what we use is inactivated or killed virus. Well, we cannot kill virus because they are not really alive. It doesn't matter. Protein subunit vaccine platforms, viral vector, platforms that are also called adenovirus vaccines, because the adenovirus is the vector, of course, and nucleic acid that in this case are known mainly as RNA. They have different advantages and disadvantages. I'm not going to talk about that. I know nothing about that actually, but I'm going just to highlight two differences that are with whole virus vaccines. You get a response to all the immunogens of the virus, and with the other three types, you only get a response to the spike protein. Another interesting difference is that for the older type of vaccines, those that are more established, you deliver the antigen in the vaccine, and with these two rather new type of vaccines, you deliver the gene, and then you rely on the host to make the antigen and then to generate the immune response. These are some maps that show the distribution of the various types of vaccines in all the countries in the world. And what we can see here, that, for example, for whole virus vaccines are not used in the Western world. They are not FDA or EMA approved. What we use mainly are the RNA vaccines, for example, Pfizer and Moderna, and viral vector vaccines, for example, the AstraZeneca and Johnson & Johnson. And it seems that there is on the way a protein vaccine. You probably heard of it, the Novavax vaccine. I showed you this because I wanted to stress that so the immunity against vaccines only generate a response to the spike protein. Okay, what about vaccine protection? Well, there's some confusion. At least I had a lot of confusion when reading papers about this, because you can measure it in use different measures, and you can use efficacy measures and effectiveness measures. And the difference is that efficacy are those that you get when you work under control situations, and effectiveness are those that you get when you work in the real world. And in fact, effectiveness not only depends on the efficacy of the vaccine, but it depends on the vaccine. It depends on a lot of other factors that are local, and you usually cannot standardize between studies. There are demographic factors, host factors, viral factors, even access factors that can modulate, increase or decrease the effectiveness of the vaccines, depending on the local conditions. To highlight this, I'm just showing this slide. That up here in red, up in red, you see the relative risk reduction of the different types of vaccines. And when looking at it, it appears that the left one, the Pfizer vaccine, seems to fare better than the AstraZeneca, for example. But when you study effectiveness with the number needed to vaccinate, you see that AstraZeneca needs less vaccinees to get the same result. So apparently the results are contradictory. This surely depends on the type of cohorts that were used to study this. So it's difficult to assess vaccine protection. The other point is, of course, that many different endpoints can be used to assess the protection. The most used perhaps for public health measures are serious disease or hospitalization rate and lethality, but the other ones should also be used to study other aspects of the viral transmission. And I've seen even people that use antibodies as a protection measure. We shall see later if this is a good idea or not. We still have, of course, many ongoing questions. Some of our, how do vaccines protect? Is there an effect of antibody besides neutralization? We talk a lot about neutralization effect. What's the role of mucosal immunity? What's the role of T cells? Do vaccines protect against transmission or not? What's going to happen with the new variants? What is happening now? What's going to happen with the new variants that will appear later? Can we find a sort of measure that could tell us something about the degree of protection that somebody has? And of course, what is the role of the clinical lab in all this? Well, actually, the clinical lab has been a crucial partner in this pandemics, as you all know, because the final diagnosis depended on the finding of the virus in the respiratory samples, of course. But what's the use of the antibodies? Well, we know that antibodies start being detected usually around the 7th day post exposure. And they peak usually also after the virus is no longer present. So for the diagnosis of the acute disease, they are probably not very, very interesting. And we know also that the size of the response depends on several factors like the viral load, the severity, the state of immunosuppression, of course, and age and so on. So there is a very big variation, inter-individual variation in the response to the infection, as I told you before. So we are now almost sure that the antibodies are not very useful for diagnosis, except on the situations that we no longer fight the virus. And these are two examples. One of them was spoken in this morning by Yehuda Schoenfeld, the post-acute sequelae of COVID, also known as chronic COVID syndrome or long COVID, and the multi-system inflammatory syndrome in children. Okay, they are also very useful for prevalence studies, and there are lots of ongoing studies that we also participate in Portugal that allow us to take public health measures, of course. But can they be used as correlates of protection, either to assess the protection post-infection or the protection post-vaccination? Well, one of the problems we have with antibodies is that we have different types of tests. The usual tests are binding antibody tests. Binding antibody tests measure the amount of antibody that recognizes a certain antigen. In this case, protein, nucleocapsid protein or spike protein or other proteins for the SARS-CoV. Neutralizing antibodies are functional antibodies. And so the gold standard for this is the virus neutralization test that uses not live SARS-CoV, because they are not really live, I don't know, but viable virus in culture, and they measure the amount of infection of cells in culture when you mix sera with antibodies. And if there is a blocking of this of the action of the virus, then you have neutralizing antibodies. You can quantify this more or less. But this is a very difficult thing to implement in usual laboratories because this requires very highly safety premises. So this is not very, very common in labs. The second type of neutralizing is the pseudovirus neutralization tests. Actually, pseudovirus are viruses that were engineered to present on their surface certain other foreign proteins, in this case, the spike protein. And you can measure the amount of internalization of these viruses inside cultured cells. And when you add, of course, sera with patients with antibodies, you can measure if they are or not blocking that entry. Not very practical neither for a common laboratory. And then have the competitive or surrogate neutralization tests that do not use virus and are more easy to set up. Actually, there are many, starting to be many available commercial kits for this, that use the reaction between the ACE2 receptor and the spike protein. And they measure the amount of blocking that antibodies can have on this reaction. So they are easy to set up. Antibody tests, especially binding antibody tests, also differ on the antigen target, on the isotype they measure, on the methodology, and of course on the units. I'm going to talk briefly. So the main antigens used currently are the anti-nucleocapsid and anti-spike, anti-N and anti-S. But there are also tests that only test for the anti-S1, and there are tests that only test for the RBD, the receptor binding domain. This is because theoretically, antibodies to the receptor binding domain sterically will interfere in the binding of the spike with the ACE2 receptor. But we must not forget that ACE2, as I told you before, is also important. So these theoretical questions sometimes do not have a reality counterpart. So nucleopeptide and spike. And as I told you before, vaccines only generate a response against the spike or against parts of the spike, against DS1 or RBD. So anti-N are specific of previous infection, and anti-S can appear both in infection and in post-vaccination. Actually, usually infection, they should appear together, but in cases, especially when the titers are low, you can find people with only anti-N or with only anti-S. And of course, when they are both negative, theoretically, they might or not be vaccinated, in fact, because some people do not grow antibodies, like immunosuppressed people can have a negative result on both even after vaccination or infection. So what about isotypes? Is it useful to measure different isotypes? Well, IgM is a lot used in infection serology, because usually it appears first and disappears later, so it can distinguish between let's say active and what I say, recent or not recent infection. Actually, here it appears almost at the same time that IgG, so it's really not very useful. And there are reports on the IgA. I would say we need more data to this. But for example, recently I saw a report that said that IgA is probably related to certain cutaneous manifestations of COVID. So people now, what we are using in the clinical lab is total IgG or only IgG. There are also lots of methodologies that we can use. This is the least interesting for us. It's something that we can do with a finger pick at our place, at our home. I'm only mentioning this because it can be confused with the rapid antigens, that they're different. Okay, so many people have confused this. I'm sure you'll never confuse this, but I'm just pointing this out. ELISA tests were the first to be developed as quantitative tests, and but they are not very easy to automate. So we mainly use, when we have automated systems in big labs, we use this type of immunoassay, chemiluminescent assays. And of course, there are a multitude of other tests that can be used and can be useful. I won't be mentioning them. What I want to highlight is that the performance of the different tests can be very variable. So there are tests that are really of no value at all, those that are lower in this curve near the blue line, and there are tests that are much better, but much better. Even when you use quantitative tests and you compare them, this is a recent comparison between several automated platforms mainly, and that can be used in regular clinical labs. Well, you see that there is a correlation between the results, of course. I'm going to highlight here, sorry. There is a correlation. If we are very optimistic, we could say that the correlation is good. I'd say it's only fair. This is something that we get also on autoantibodies. But when you look, for example, at a result of 2,000 units in the Abbott, give a result of less than 200 in the Roche system. So to standardize this, an international standard was prepared by the WHO, trying to and we tried to see if this could resolve this problem. These are the results with the same sera and the same tests. Well, the correlation stays the same because this is just a transformation of the results. But also you see that there is still no interchangeability. To be interchangeability, all the results should have to be on this line, along this line. And for example, a result of 500 Abbott assays will give around 300 in the Roche. It's a little bit better, but not I think that really not good, especially here or here. It's really very different results. Also, again, another thing that happens quite frequently with autoantibodies. Another strange thing is that this is a cohort of patients, post-COVID patients that were followed for 6 months with several platforms, several different types of tests. And you can see that, for example, here, it seems that the antibodies decrease with time, but when you look at other tests, it seems that they do not decrease. So they are using the same samples, of course. So this is really puzzling. What about the correlation with the neutralization assays? There has been a lot of work with this. Most of the work that we read about antibodies, when speaking of protection, what they do really is only compare binding antibodies with neutralization antibodies, and we do not know the role of the other antibodies that are not neutralizing. We do not know that role. They probably play an important role. So there is also, you can see up up here, there is a correlation. Each one of us can have an opinion if the correlation is good or not. So, but most studies report that there is a correlation, of course, between binding antibodies and neutralizing antibodies. But what about protection? Can we use some sort of level of antibodies that can guarantee us that a certain person has a certain probability of being protected? There are lots of studies that say that on average, the higher the antibody response, the higher the protection it will be. We'll, of course, have to be very careful because what kind of endpoints are they studying? Efficacy or effectiveness, what kind of endpoints are they using, and so on. But so on average, there is probably a relationship. Most studies say that, but in reality, you cannot say that for this test, above this level, you have this degree of protection. And so the FDA does really not recommend the use of antibodies to assess immunity after COVID vaccination. Anyway, we didn't know this when we started our vaccination process in our hospital. So we started with a cohort with more than 1,200 healthcare workers, and then we joined some nursing home residents, and we studied them. And this is the results for the first dose response and for the second dose response. And some things, what we got is what we are reading all over the literature. So the first dose response, this was the Pfizer vaccine. The first dose response was very heterogeneous. It has an age dependency and also sex dependency, like Yehuda Schoenfeld this morning predicted. And there's a more homogeneous and much higher response at the second dose. We also have longitudinal data. I'm not going to speak to comment on these results because now we have already the 3-month and the 6 months results. And what I'm showing here is that in white are the cohort of participants that have no evidence of previous infection, and in green, the 23 participants that have an anti-N positive already before the first vaccination. So although they do not remember being symptomatic, so apparently they had an asymptomatic infection, they had an infection, and it's interesting to know that with only one dose, these guys get a very, very high response, something that the others only get after the second response. We see here the heterogeneity of the first dose response, and we also see that between the 3rd and the 6 months, apparently there is not a great decay, which is, we don't know if promising or not. We'll see later. And so we'll have to wait and see what we get from here. The other thing that we got is also we have less than 2% participants during the 6-month follow-up period that got infected. And we also had one participant that was a non-responder to the first, neither to the second dose. I marked him here. Actually, this guy is a colleague of ours with an RA. He's in treatment, and he got his 3rd dose now. We got the results after control of the 3rd dose, and he finally got antibodies. So he was very happy with these antibodies, although we don't know exactly what kind of protection he has. To assess the effectivity, we are now engaging with this international study, European study by the CDC, and with that in Portugal is coordinated by the National Institute of Health, with 500 of our healthcare workers are responding to a weekly clinical report, and we hope that around April next year we'll have some data, some international data on the effectiveness of the vaccine. So, in summary, I would say that infection antibodies are different from vaccine antibodies. Yeah, this is very important because many people got their tests for antibodies and they were very disappointed because they had no antibodies. Of course, they tested for N. They couldn't have antibodies after vaccine, but this happened a lot in the beginning. Apparently, for now, there is a limited value of measuring isotypes, so we can measure usually IgG or total Ig. Different methods, unfortunately, will still give us different results, something that we share with autoimmunity, of course. They are not very useful for diagnosis, except for the situations that I showed you before. They are useful for prevalence studies, and for now, we cannot recommend them to be used as correlates of protection. We cannot say that this patient with these antibodies has this probability of getting infected, unfortunately for now. Of course, there's a lot of work going on, even with all these difficulties in finding endpoints and in standardizing the studies. So who knows that somewhere in the future we'll have some more data and some more useful data for antibodies. Thank you very much.
Thank you, João. I don't know if we have, yes, one question up there, Jan.
Thank you very much for sharing the data, and perhaps you can solve a problem that I always encounter. You talked about this receptor recognizing domain antibodies, and I actually don't know, I don't understand what the receptor really is. Is there an ACE2 receptor, as you showed in your pictures? Because in some figures in other journals, you find it's just ACE2. So what is really happening? Do these viruses bind to ACE2 that is binding to some kind of receptor, or do they really bind to an ACE2 receptor irrespective of ACE2? Do you know that?
That's a very difficult question. Actually, what I read is the ACE2 receptor that is present on the cell. But that's what I read.
That's what I also understood, but you very often see pictures where they just say ACE2. And there is surface ACE2 binding should then be the kind of receptor for the virus, but I also don't understand.
Yeah, I think it's the ACE2 receptor, yes.
Another question here.
Congratulations, João, for your excellent talk. But and what about cellular response? What about T cells and memory cells? Can we measure them? Is any good for our orientation and to appreciate the response from our immunocompromised patients?
Thank you for the question. That's a very interesting question. Actually, there are some, well, there is the clinical lab, the normal clinical lab, and there's the research lab. On the research lab, you can do much more studies, but if they are not practical enough to be used on clinical labs, they won't have any effect on the patients. Because, nowadays we are also able to study some of the T cell response. For example, with IgRA type of tests, they use IgRA like for tuberculosis, but instead they use peptides from the SARS-CoV virus. That test is already being used. What is its usefulness? I think we'll have to wait to see if it is useful alone or in combination with antibodies. There are also some things called the ELISpot assays that harvest cells from the person that you want to investigate, and then you detect the production. When you stimulate these cells with viral proteins, and you see the capacity of these cells to produce cytokines or whatever. You mark them, and you can measure the amount. For example, they say that they can measure the B memory cells, for example, and they can measure T cell secreting interferon or other cytokines. But these tests are not they are not standardized yet. They are very difficult to perform. And as you said, this is the response is very complex. So we still don't know. They are not practical. We cannot use them. So we'll have to wait and see. Technology is also evolving very fast. And so if something is useful, someone will come up with some solution for the clinical labs. I think so.
Any other question? Do you think that the cellular methods may be useful, for example, to choose patients for the third dose of vaccine?
I have no evidence of anything. I think as cellular tests are not so prevalent, there are much less studies with these cellular tests. So to get real strong evidence for them, it's going to be much harder. But anyway, at this moment, there's no recommendation that antibodies or other types of measurement of immune response should be used as a means of selecting people to be or not to receive or not the third dose.
Thank you. So thank you very much. We move to the next lecture. Thank you, João.
Well, it's a significant pleasure for me to be on the table with Maria José. Sorry, not just because I'm a friend of hers, but because I significantly admire her work, both on the clinical pathology field, but also in the university. Maria José is one of she's the chief medical officer, let's say it like this in English, for one of the biggest groups, private groups in terms of clinical pathology, the Germano group. By the way, I'm from the other side of the border because I'm coming from Unilab, so no competing, okay? I am significantly admirer of her, and but she's also a person associated with the university, where she in Lisbon is responsible for clinical medical lab share in the University Nova. And by the way, also in the Catholic Medical School, she's a member of the pedagogic board. And also she's sharing one of the units associated with regulation, and well, the name she will be capable of speaking of, and the field. But this means that we have on Maria José one of the significant persons in terms of both clinical pathology and academic approach of the field of lab. So thank you very much, and up to you now.
Thank you so much, João, for introducing me with so many kind words, and I have to thank Carlos Dias for this invitation and Carlos Vasconcelos for both of them for the resilience of holding this Congress with such an importance themes of autoimmunity here in Portugal, because it's really the main encounter for treating these teams. So Carlos Dias made me this challenge of speaking about the dialogue of the laboratory with the clinicians. And I have to be very front with you. From my point of view of a clinical pathologist, it was a very arid theme to bring to you clinicians. We deal with the whole medicine, and you deal with autoimmunity, although you are internal medicine specialists. So I was quite afraid of bringing this theme of dialogue with the clinicians and the value of the clinical laboratory. But even so, I thought of some strategies, and I hope that you won't fall asleep during the presentation. Like João Fardiana, we also had our hands full during the pandemics because, the workload was crazy. But before that, and of course now after, and in these last days and afterwards, the clinical laboratories have our hands full because of these quite simple things that you all know. The growing of the aging population and its chronic diseases that come along with them, the rapidly evolving technology, the increased availability of testing, the increased reliance on testing, which makes more adoption, and the adoption of the preventive medicine, the fact that the patients are more informed, and of course we contribute to cost and time savings. But if this is true for the whole activity of clinical laboratories, this is also very much true for the activity of autoimmunity laboratories. We had a very growing pattern that will continue in the future. Well, for decades now, we have been having some strategies, implementing tasks and processes, and I will not detail each one of these items for increasing and then adding value to the clinical laboratory services. I like to say, and I found this expression very effective, we implemented through science all the tasks and processes that increase value through standardization and harmonization. That is a going on process, but very important, because without this, we don't control our main core activity, the ones that now we can say that is absolutely controlled and doesn't produce errors. We are, of course, very much interested in cost effectiveness. And of course, we have to innovate and to apply novel applications and work according to evidence-based laboratory medicine. But we are centered in the modern laboratory in the clinical effectiveness. We want to have optimal clinical outcomes for our patients. And if 40 years ago, Lundberg created this concept of the brain-to-brain loop, in which the laboratory cycle is included, and the classical one you know, from the pre to the post-analytical, passing through the analytical process. Lundberg created the concept of pre-pre and post-analytical phases, which was centered in one brain only, the clinician brain. So everything started in the clinician brain and ended in the clinician brain. Well, but concerns came along regarding, well, but okay, our processes are very, very controlled. We don't produce, infamous errors now. We produce infamous errors now. So is the actionable laboratory result really taking action in the hands of the clinicians? Is clinicians doing something with our results and something that is effective for the outcome of patients? There were concerns about that, about patient safety based on laboratory results. Some much years later, and not so long ago, the same authors, together with Plebani and La Posata, came with this new concept, which was, well, let's introduce another brain here, the laboratorian's brain, that goes hand in hand with the clinician's brain. Together, intricated, they dialogue, and they decide together which tests should be prescribed, which tests should be in reflex or in follow-up be prescribed, and interpreted them together, bringing results already interpreted and with reports that are able to help, because of the complexity, like I said, could really help clinicians to act on those results. So now, be afraid, maybe or not, of laboratory brain power. The power begins with the release of the results. Because what we really want, and we are stating our will now and occupying our place, I think, together with a physician, with other healthcare professionals, we are representing here the result and the sample around the patient and putting the patient in the center of the system. And laboratory medical specialists are outside the laboratory, being part of the multidisciplinary team that seeks the optimal clinical patient outcome. But where are we going? Do we want to be where you are? No, I don't think we do. We don't. It's not our vocation. We want to be in the laboratory still. But we want to be, clinical pathologists, laboratory scientists, we want to be equal partners on healthcare teams, because, and this is now, we consult, advise, and assist clinicians. We provide in-laboratory interpretations. We order follow-up tests, developing pathways and reflex test algorithms, contributes to doctor-driven clinical pathways, contribute to triage protocols, formation of rules, alerts, orders, sets, and algorithms. Medical practice, we belong to medical practice committees and infection control committees. We, of course, are engaged since ever in quality assurance, in laboratory management, and professional advocacy and education, at least, last but not least. And with the personalized medicine that involves molecular biology technologies, very complex, that produce very complex results, even if involving bioinformatics, we are now able to predict and prevent a large number of diseases and make early diagnosis for molecular changes and applying therapy aimed for those specific molecular changes and monitor treatment responses. So nowadays, with the help of bioinformatics, laboratorians are able to, based on an individual clinical information, genomic profile, and lifestyle info, give results in a medicine, personalized medicine. And this personalized medicine is a change of paradigm that brings and gives people the greater opportunity of preventing their illnesses before they become ill. But this will only be possible with a greater communication between laboratory and clinic. A new language will be developed based on this molecular basis of disease, and healthcare will become more individualized. Well, since ever, and since I became a clinical pathology specialist in 2000 something, I think 2000 really, I worry about communication with clinicians. I worry about how our results are given to clinicians. So we have in our laboratory, the private one that João so kindly spoke about, we assembled a group of clinical cases, and we worried about how to explain to our clinicians, the one that trust us, how to explain them that we really need to be in the center. We want to be with them in the center of the diagnosis, because laboratory is in the center of clinical practice. So we printed and published an internal publication, which is outside in the table if you want to take one home. A book with 10 clinical cases in 2019, and we have another one. It was just before pandemic, so we wanted to have another one in 2020, but it's going to be released by the end of this year. And out of those 10 cases, I took these 3 because these 3 are about autoimmunity naturally. So in case 1, I bring you a female, 30 years old, born in Angola, diagnosed with lupus in 2005 under methotrexate and cyclosporine since 10 years ago. And in 2014, she presents with knee and elbow arthralgias, with morning stiffness that lasted more than 2 hours, plus abdominal pain, fever, and intense fatigue. The laboratory evaluation revealed the already usual ANA nuclear homogeneous pattern, the now called AC1, with a high titer, but a new cytoplasmic fibrillar linear pattern, the AC15, highly suggestive of the presence of asthma, later on characterized as anti-F-actin, emerged. The laboratory report then in 2014 that was sent to the clinician stated clearly all the patterns that I said to you, and also stated a small, very small report indicating that if clinical picture suggested that it was justified to study these specificities, they should be studied because they were associated with a certain number of diseases that was associated with this pattern. Well, in this case, there were different responses in some other cases, but in this case, the clinician came only with the serological patterns for certain infections that, of course, were needed to exclude that were or not present in this patient. And the results for these serological infections was not relevant. So they were excluded from the clinical picture. And the report, and here we can see a little very borderline alterations in the alanine transaminase, and we can see that the report afterwards, when the asking for the antigens, the specific antigens came, the report stated clearly that she had an F-actin. So it was good that in the midst of the thousands and thousands of patients that we see per day, the clinical pathologist was there after being screened in the automatic immunofluorescence laboratory microscope that we have. It was good that the clinical pathologist was there to be able to detect the difference in this patient and, of course, in others. So the change in the pattern of anti-nuclear antibodies requires a laboratory investigation geared towards the search for specific markers such as soluble liver antigen, asthma with specificity for F-actin, and other hepatic microsoluble antigens like LKM1 and 2 and 3 antibodies, which are generally not found in SLE, but which are associated with autoimmune hepatitis. Since the diagnosis of autoimmune hepatitis is relevant for patients with SLE, as it influences the choice of immunosuppressants and the long-term results, special attention should be paid to differentiating between the association of autoimmune hepatitis and non-specific hepatic involvement of SLE. I'm sorry for the acronyms. Elevated liver enzymes, as you saw, are common in SLE. So lupus-associated liver must be differentiated from hepatitis caused by drugs, toxins, viral diseases, and other autoimmune diseases. The differential diagnosis of abnormal liver function tests in SLE patients with non-specific liver involvement or with autoimmune hepatitis is clinically demanding, and the laboratory clinical interface is of fundamental importance, resulting in better knowledge and application of the various laboratory tests in decisional algorithms. In our case too, we have a female, 26-year-old, diagnosed with celiac disease in 2015, initiated gluten-free diet with significant improvement of her gastrointestinal symptoms. In 2016, she presents severe osteoarticular pain with small and medium joints of the upper limbs involvement, mild abdominal discomfort, and fatigue. The serological profile of celiac disease was negative as she maintained gluten-free diet, and ANA revealed a multiple nuclear dot pattern, AC6, and nuclear fine speckled pattern, AC19, and a cytoplasmatic fine speckled pattern suggestive of anti-Jo1 antibody confirmed in immunoblot ENA profile, scleroderma, and myositis profile. This was a different situation. Here, we communicated to the clinician in a very proximity relationship, and the clinician came with the asking of the specificities for being studied. So we did the immunoblotting for the specificities, and they came positive. So the patient had a TOPO1 and a Jo1 positivity, besides, of course, her celiac disease. So, and here we can see in the report statement the positivities for the specificities that I referred. Okay. So the celiac disease and scleroderma are systemic autoimmune diseases and both affect the gastrointestinal tract. Some studies report that the prevalence of celiac disease in patients with scleroderma is higher than in the general population. She was referred to the rheumatologist and was diagnosed with the association of these two diseases. She was given corticotherapy associated with the gluten-free diet, and within few months, she reported a complete resolution of her pain and fatigue, maintaining her activities, their daily activities. The patient clinical progression showed that the diagnosis of celiac and scleroderma can be made in a very short time interval between them, the appearance of both of the diseases, with the appearance of the associated antibodies for scleroderma in less than 1 year. And although the gluten-free therapy is standard, the concomitant appearance of and association of other autoimmune disease may require immunosuppressive therapy with corticosteroids or monoclonal biological antibodies. In our third case, this is a very atypical situation that we wanted to show clinicians. The use of ELE tests still. So we have a female, 53 years old, leucodermic with clinical picture of anorexia, marked asthenia, weight loss, odynophagia, and high fever with about 1 month evolution. On physical examination, she presented with edema of the palate, ulcers of the oral mucosa, urticarial exanthematic lesions of the dorso and lower limbs, and small cervical and inguinal adenopathies. The CBC revealed bicytopenia with an error here. Normocytic and normochromic anemia, and hyperregenerative anemia, and leukopenia and lymphocytopenia. In the smear, the peripheral blood smear, there were erythrocytes rouleaux were observed without other significant alterations. You can see here the CBC and some other, and the ferritin, and you can see the bicytopenia. In order to clarify the bicytopenia and the febrile condition, it was mandatory to do the morphological study of the bone marrow, and the LE cells were evident. As you can see here in the picture, they were observed either the neutrophils that were with inclusions, either the rosettes surrounded by neutrophils, the amorphous substance surrounded by neutrophils. And again, here we communicated directly with the clinician that came with the tests for the specificities and the diagnosis of SLE with the ANA test. So the ANA patterns found was a nuclear homogeneous AC1 with a high titer, and the immunoblot revealed the presence of anti-ribosomal P, anti-histone, and anti-nucleosomes antibodies related to SLE drug-induced diagnosis or active or inactive SLE. So you know all about AC1 and you know all about LE cells. I just will read the conclusions. LE cell research was considered for decades and before antibody research a screening test and the most specific test for diagnosing SLE. Although it has become, of course, the obsolete test, the observation of LE cells in a bone marrow aspirate is in an unsuspected clinical case of SLE, namely to clarify cytopenias, can provide important guidance for its diagnosis and should not be underestimated in clinical practice. And I should state here that either the hematological and the immunological departments had to be here also inside the laboratory together and talking together with each other. So like Mike Woolworth from the IFCC task force, for the impact of laboratory medicine and clinical management, I agree with his statement that that's why in the future, I hope, and I also hope that laboratory medicine professionals who choose to work in relevant areas will take the leading role in improving patient care so that together we can ensure that laboratory medicine is a true clinical specialty rather than simply a number generating service The rewards are better for patient care and for job satisfaction for those who work in laboratories, a win-win situation. So thank you very much for not sleeping, I hope still yet, and I've finished.
Also, I used to say at this moment that these sort of cases wouldn't be possible if there was no communication between both the lab and the clinicians. So don't be shy, pick up the phone and call. And learn to know who's working with the samples that worry you.
Professor Maria José, thank you so much for your elegant and very clear presentation. But I still have two doubts. Regarding the enormous importance that we have for the dialogue between clinicians and the laboratory, you feel that as today we have reached the right level, or we are still far away from it? And so, if we are still far away from it, what will be the strategy to get the right level? That will be the first question. The second question is regarding prevention. We all know that strategically, in order to have a sustainable healthcare system, we do need to invest a lot in prevention. As today, it's almost not more than 2% that is invested in prevention. In this particular sector, what will be the critical role of the laboratory in the future for prevention?
Let's hope I can answer both questions. I'm not totally sure. Well, regarding the first one, I don't think that we are exactly where we both would like us to be. I think there's a long way, but for sure, for the last 20 years, we have been making progresses in reaching that place. And for sure that people like Carlos Dias and Carlos Vasconcelos had a great role in helping laboratory came out to congresses, to internal medicine congresses, and speak in the podium and state their concerns and their work. So for reaching there, education, for sure, our own education, coming out of laboratories, participate, like I said, we have to be there, and be enrolled in works like EASI that joins, and you were also in the formation of our EASI Portuguese group, being together with clinicians, enrolling works that brings together the knowledge of both specialities, empowering naturally those specialities. So I think the first question is more or less answered. Regarding prevention and our role, the clinical laboratory role in prevention of diseases. Well, of course, what I see regarding that item is that genetics is going to be the fundamental key partner in prevention, because we, like I said, laboratory services are able now to give a lot of predictive tests for an enormous number of diseases. Of course, that's not all, but personalized medicine is really a reality now. But they are expensive tests, and that is the problem. How much can we support, how much the system can support the prevention using genomic tests? I don't have the answer for that.
Any other questions?
With the growing tests that we have all days, the overdiagnosis is a problem for us. You think so?
You are a clinical pathologist, right? No, no.
No.
Oh,
Yeah.
okay. Oh, I'm sorry. With the mask, I cannot. Yes. So there is an overdiagnosis. Yes, of course there is. And that's one of the problems that, you know, these kind of papers from Lundberg and Laposata and etc. address precisely the worry of the laboratory. It's the overuse of the laboratory and the overproduction of results that comes out of it. So that's why we also defend that we should be together with the clinicians, helping them to and eventually, I'm sorry, educate them to prescribe better. One of the things that maybe it was inside the question of Paulo Sequeira Dias was also, there was never the courage. Of course, in public hospitals, there is the courage. In some of them, in others not. But there was never the courage, and there was always the suspicious about giving laboratorians the power of being ethical professionals and being there to choose the reflex and the follow-up testing, because there will be savings with that attitude, savings for all the system, and of course, not over-diagnosing.
Just a comment. The first case, well, the lupus and the hepatitis was a successful case, but there is a message that it should accompany the slide. Don't ask Anna after the first result, right? So over-diagnose, over-tests are not so good. But in that case, it was a success. Indeed, if he has no infection, the clinician should ask the autoantibodies for hepatitis.
Sorry for the interruption, but we are now already past the due time. So let's move to the next meeting. Tiago.
So now we get to one of the advantages or not of COVID-19 is that now we have the possibility to listen to the next lecture, being here in Porto, probably from Leuven in Belgium. Xavier Bossuit, he is going to talk about how to, in the end, how to interpret or to standardize this interpretation of tests. Thank you, Xavier, for being with us. I don't know if it's already raining a lot in Belgium or not. We still have some sunshine here in Porto. Of course, it's a pity you are not here with us, but it's very nice to have the opportunity to listen to your lecture from Leuven. Thank you very much for your presence in this session.
Thanks a lot for this nice introduction, and also my sincere thanks to the organizers for inviting me to participate in this meeting. I indeed apologize for not being able to be physically present, and I am sure that all of you that are present will enjoy the meeting after such a long period of difficult time that we all experienced. So I indeed will try to give some ideas how we can improve communicating diagnostic information. And I also will try to give some hints how we could standardize test interpretation. As a matter of fact, we usually report test results as positive or negative. That's a dichotomous interpretation. However, we all feel and know that, for example, for antibodies, the higher the antibody level, the higher the chance that the patient has this disease. And I will try to find ways to communicate that information that in a positive, negative way is not communicated. And in order to do that, one could use the concept of likelihood ratio. And let me explain a little bit what it is about. When we look here at the left-hand panel, here you can see the frequency distribution of test results in a control population here in blue and in a patient population here in brown red. And one could put the cutoff here where the green line is indicated. But as you can see, there is some overlap between controls and patients. And when you look at the cutoff here around 5, then you will see that the fraction of patients here is the same as the fraction of the controls that has such a test result. So when you would calculate the ratio of the fraction of patients with a test result of 5 and the fraction of controls, it would be 1. And this is indicated here on the right-hand y-axis. So this test result here is associated with a likelihood ratio of 1. And the likelihood ratio, this is simply the ratio of the fraction of patients with a particular test results to the fraction of controls with that same test result. And as you can see, you can do that for each individual test result. And in that case, for test results that are higher than this cutoff value, the ratio of the fraction of patients to the fraction of controls will be higher than 1. And the higher the test result, the higher the likelihood ratio. And for test results that are lower than this cutoff point, well, then the likelihood ratio will be lower than 1 because you have less patients with such a test result than you have controls with such test result. So this is, let's say, a graphical representation of the concept of likelihood ratio. The right-hand panel, and I think you're all familiar with this, this is a receiver operating characteristics curve of a test that has the same performance characteristics as here. And so this is the black line, this is the rock curve, what we, how we name it. And this here, at this point, this corresponds to the cutoff. And the cutoff, what you can see is this cutoff corresponds to a sensitivity of around 80% and a specificity around 88, 89%. And the likelihood ratio, when you use such a representation, this is the tangent to the rock curve at this particular point. And this is here 1, as it is here also 1. And you can calculate for each cutoff point the tangent and you get the likelihood ratio. But you could also calculate the likelihood ratio using a single cutoff point, for example here. Then it means that you look at the ratio of all the patients that are positive to the ratio of all the controls that have a positive value. And on such a graph, it is the slope of the line that starts here and goes through that cutoff point. This is the positive likelihood ratio, and the slope of this line represents the negative likelihood ratio. Just a little bit, some theoretical background. And we can apply that. We can apply that likelihood ratio concept for each particular test result. We can apply it for a single cutoff, we can also apply it for test results intervals. For example, this is here for CCP antibodies, a negative result, a weak positive result, or a strong positive result. And what you see here is the fraction of patients in gray with such particular results, and this is the fraction of the controls with such results. So for the negative result, you have more controls than patients. The likelihood ratio is less than 1.2. A weak positive is the ratio of the fraction of this gray to the fraction of this open bars, that's 4.5. And for a high positive test result, of course, you have more patients than controls, and you have a higher likelihood ratio. So one can get an intuitive feeling of what it means, a likelihood ratio. A likelihood ratio of 1, for example, means that your test really is not helpful to decide whether it's going to be a patient or a control. But if you have a likelihood ratio of 10, then you know that this particular test result is 10 times more frequently found in a patient than in a control. And if your likelihood ratio, for example, is 0.1, it means that this particular test result is 10 times less frequently found in a patient than in a control. So the likelihood ratio of 10 or higher are helpful to support the diagnosis, whereas likelihood ratios less than 0.1 are helpful to exclude the diagnosis. You can even go a step further and you can estimate the post-test probability for disease based on the pre-test probability and on your test result, and more particularly on the likelihood ratio associated with your test result. So this is the post-test probability for a high positive anti-CCP test result, a weak positive, and a negative result. And in order to calculate this post-test probability based on the likelihood ratio and your pre-test probability, there are some simple formulas that you can use. The post-test odds equals the pre-test odds multiplied with the likelihood ratio. Of course, we are not used to calculate in odds or to use odds, and there are a number of other simple formulas to go from probability to odds. So the odds is the probability divided by 1 minus the probability, and the probability equals the odds divided 1 plus the odds. So this as an introduction, as some background, and now we will show some examples in which we have applied these concepts. And let's start with ANCA-associated vasculitis. So recently we published a position paper in which we state that we can harmonize interpretation of ANCA by reporting test result specific likelihood ratios. And let me explain that. So the data I'm going to show are based on a large international study, including 251 diagnostic samples of patients with ANCA-associated vasculitis and of more than 920 diseased controls for European centers participated. And based on these results that we obtained, we could make these figures. And let's focus here on the left upper part, in which you see the distribution of the test results obtained with a INOVA from ELISA in that case, the distribution of test results in the diseased controls, this is the blue curve, and in the ANCA-associated vasculitis patients. So this is a similar approach as I have shown in the figure in the introduction. And we also calculated the test result specific likelihood ratios, and these are these yellow symbols here. And this is given on the right y-axis. And you see this is the likelihood ratio of 1. So we determined that a test result of 13.8 corresponds to a likelihood ratio of 1. So if you have a patient with such test result, yeah, the chance that it is a patient or is a control is equal. A test result of 35 corresponds to a likelihood ratio of 10. So if you have such test results are found 10 times more frequently in patients than in controls. And this value of 82, this corresponds to a likelihood ratio of 30. And you also identified the test result that corresponded to a likelihood ratio of 0.1. This is 6. So all values lower than this 6 value, these have a likelihood ratio that is less than 0.1. And we have done that for several commercially available assays. We will not go over that. You can see the figures and some additional assays. So, and when we summarize all these data, and in this figure, on the y-axis, we have the assay-specific test result that corresponds to a likelihood ratio here on the x-axis of 0.1, 1, 10, or 30. And when you do that for all of these different assays, you see the following curves. Of course, the values do not correspond between the different assays, but strikingly, all these curves are parallel. So it means that, as a matter of fact, the interpretation in terms of likelihood ratios is very comparable between these different assays, but the numerical values differ. And all these data are summarized in this table here. And this table just shows you the fraction of patients with all these different commercially available assays that give a likelihood ratio higher than 30 in the patients. And you see that the fraction of patients with such high likelihood ratio also is quite comparable across the different assays. And this is the same for test results that have a likelihood ratio between 10 and 30, between 1 and 10, and so on. So you see that in that way, you can have a clinical interpretation, you can harmonize the clinical interpretation between assays. And very recently, we look at the data that we got from an external quality control scheme. The external quality control in Belgium is organized by the Public Health Institute, the CNSANO is it called. And for example, here, a sample from a patient with ANCA-associated vasculitis was distributed, and we have here data from 59 different labs using different commercially available assays. Well, all these labs, all of them, reported a test result that when we calculate the likelihood ratio that is associated with that test result, it was higher than 30. All of the labs reported a test result associated with a likelihood ratio higher than 30. So the clinical interpretation across all these labs was the same for that particular diagnostic sample of a patient. And they all reported a likelihood ratio for MPO ANCA that was less than 0.1. Just a very practical illustration of how we really can harmonize to a certain extent interpretation of test results. So current immunoassays for ANCA classically apply a single cutoff point with a dichotomous interpretation, positive or negative. But there we propose to employ test result specific likelihood ratios to align test result interpretation across assays and manufacturers, and to convey clinical information intrinsic to the antibody level. And now let's move to antinuclear antibodies. And first of all, I would like to focus a little bit on the new SLE classification criteria. And just putting it a little bit in a historical perspective, there was a large systematic literature review and the meta-regression analysis of diagnostic data on lupus. It included more than 13,000 lupus patients and more than 7,500 controls. And the conclusion out of this analysis was that antinuclear antibodies by indirect immune fluorescence at a titer of at least 1 in 80 has a high sensitivity for lupus. And based on this paper and on this analysis, in the new lupus classification criteria, SLE classification criteria, antinuclear antibodies by indirect immune fluorescence at a titer of at least 1 in 80 was positioned as an entry criterion. And very recently, the same authors that published the classification criteria, well, they evaluated or studied the criteria item performance of these new classification criteria. And they conclude that antinuclear antibodies are a useful screening test for SLE, but not specific. And they also stressed that the classification criteria should not be used as diagnostic criteria. So based on all these data, we try to illustrate how we can again use the concept of likelihood ratio to get a better understanding of what is happening. So here in the left-hand part, the data published in this large meta-analysis is shown. And in that paper, you can find data for sensitivity and specificity at different cutoff points for antinuclear antibody testing. And when we use these data published in that paper, we can calculate likelihood ratios for each of these cutoff points. For example, when you use a threshold of 1 in 80, then all test results of 1 in 80 or higher than 1 in 80 are associated with a likelihood ratio of 3.87. And it is higher when we use a threshold of 1 in 160. But such calculation, this typically is based on a single cutoff. This means all antinuclear antibodies of 1 in 80 and higher, well, when you consider them all as a group, then you have a likelihood ratio of 3.8. And you would think, yes, a likelihood ratio of 3.8, that's good, that's higher than 1. That's more, you have a higher chance that you have lupus than that you do not have lupus. However, based on these data, we also calculated the titer specific likelihood ratio. This means that if you have a test result of 1 in 80, what is then for very specifically 1 in 80, the likelihood ratio associated with that result? Well, when you do that, you have a likelihood ratio of 0.17. And for the 1 in 160, 0.94, almost 1. This means that if you have a result of 1 in 80 associated with a likelihood ratio of 0.17, almost 0.2, it means that the chance that you do not have lupus is 5 times higher than the chance that you have lupus. So it puts the things a little bit in perspective. And indeed, the 1 in 80 is not associated with high specificity, but this here now really, by using likelihood ratios, you get more insight in the clinical value of that specific test result. Of course, if you have a higher titer, higher than 320, then your likelihood ratio increases. Again, it's the same concept that the higher the antibody titer, the higher the likelihood ratio, but here we could quantify the likelihood ratios. So let's move to a study that we have done on antinuclear antibody. We included diagnostic samples of 480 patients with what we call the ANA-associated systemic rheumatic diseases, lupus, Sjögren's, systemic sclerosis, myopathies, mixed connective tissue disease, and more than 760 diseased controls and also including blood donors. We evaluated these patients and these controls using an automated system for indirect immunofluorescence and using automated systems for that screen for a mixture of relevant autoantibodies directed to these autoantigens. And the results are shown here. Here you see for the indirect immunofluorescence, you see the distribution of the controls, and here in red, the distribution of the patients. And again, the right-hand y-axis, the likelihood ratio. And you see a likelihood ratio, in that case, that corresponds to a likelihood ratio of 1 is that value, around 300, I believe. And this is the cutoff of the company. You see that the cutoff corresponds to a likelihood ratio that is clearly below a test value of likelihood ratio of 1. So in that region, you will have many test results associated with low likelihood ratio, with a low chance that these individuals have a systemic rheumatic disease. This is for the solid phase assays from the FEA and the CLIA technique. In green, the controls, in red, the patients. And again, here, the likelihood ratios associated with these test results. And here, the likelihood ratio that corresponds to 1 is 1. And this is exactly where the cutoff of the company is. So this cutoff really is aligned to a likelihood ratio of 1, whereas this is not the case with indirect immunofluorescence. And this is from another company. So again, here, we could indicate the test results that, or define the test results that correspond to likelihood ratio of 0.1, 1, 3, and 10 with the different systems, indirect immunofluorescence, and also solid phase assays. And again, that can help you to interpret the test results. We can break down that to the individual diseases. We will not go into detail, but as you might know, some diseases are associated with some lower titers, whereas other diseases have higher titers, and this is reflected in the disease-specific likelihood ratio. So by defining test result-specific likelihood ratio, clinical interpretation of antinuclear antibody test results can be improved and even harmonized across assays and suppliers. And finally, some words on rheumatoid arthritis. Rheumatoid factor and ACPA are the assays that are commonly used for this disease. I will show some data that we obtained. It is not yet published by a large multi-center study in which 11 hospitals were included across 7 countries. You all know about the classification criteria for rheumatoid arthritis. And in these classification criteria, rheumatoid factor is included and ACPA are included, and the points, the weights that are given to these antibodies, they differ between a low positive test result and a high positive test result, and a high positive test result is defined by a value higher than 3 times the upper limit of normal. We included diagnostic patients with rheumatoid arthritis, almost 400, healthy controls, consecutive diseased controls, patients that went to a rheumatologist for whom the rheumatoid arthritis was in the differential diagnosis. And we also included a number of really relevant disease controls, such as osteoarthritis, psoriatic arthritis, reactive arthritis, spondyloarthritis, and some lupus and Sjögren's syndrome patients. So this is summary. These are the different commercially available assays that we evaluated for rheumatoid factor. And you see when you use the cutoff proposed by the manufacturer, your sensitivity varies between 52% and 74%. So depending on the commercial assay that you use, you see clear differences in sensitivities and consequently also in specificity. The ranges is between 94% and 72%. This is for the ACPA. Here again, there is a variation between assays with regard to sensitivity, 58% compared to 65%, and the specificity 98% compared to 95%. The variation is less pronounced for ACPA than for rheumatoid factor. So, but here again, we can harmonize interpretation between different companies. And the approach that we used was, we looked at thresholds corresponding to a specificity of 90%, 92.5%, 95% specificity, 97.5% specificity. And this is the ROC curve for these cutoffs that correspond to these specificities. And what we next did is we just defined test result intervals, one here, then the other one between the threshold that corresponds to 90% and 92.5%, and so on, 95%, 97.5%. And the likelihood ratios associated with these thresholds, with these intervals here, this is the slope of the ROC curve. This is here. This are the likelihood ratios. Or you can also present it in another way, the different test result intervals. So these are the different intervals, and these are the patient with a test result in that interval and the controls, and the likelihood ratio is the ratio of this fraction divided by this fraction. Anyway, again, these are the different test result intervals. The likelihood ratio again clearly increases with increasing test results. And this is for the Beckman-Coulter assay. This is for another assay from Roche. You see again this clear increase of the likelihood ratio as a function of your antibody level. And when you do that in such a systematic way, and you do that in the same way for the different assays, you see that the likelihood ratios are very comparable across the assays. And you can do exactly the same for the ACPA. Again, you define different test result intervals, you calculate the likelihood ratio, and you see again an increase of the likelihood ratio as a function of the antibody level. This is an example for the assay from Thermo Fisher. This is the an ELISA from Organtec. Again, the same kind of increase in likelihood ratio. This is the likelihood ratios for assays from Siemens for rheumatoid factor and ACPA, just when we apply the classification criteria, the 2010 classification criteria for rheumatoid arthritis, so in which they defined negative, low positive, and high positive. And this is for rheumatoid factor. The likelihood ratio, again, increases with increasing antibody titers. And this is for ACPA. And you clearly see that a high positive ACPA has a clearly higher likelihood ratio than a high positive rheumatoid factor. The specificity of ACPA, of course, is higher than of rheumatoid factor. And you can also look at combinations of rheumatoid factor and ACPA. And this is shown on the right-hand panel here. What you can see here, this first part is negativity for ACPA combined with negativity, low positivity, or high positivity of rheumatoid factor. In all these cases, you have low likelihood ratios. This is low positivity for ACPA in combination with negativity for rheumatoid factor, low positivity for rheumatoid factor, and high positivity for rheumatoid factor. You see here again that the likelihood ratio gradually increases with positivity and high positivity for rheumatoid factor. And these three conditions are high positivity for ACPA in combination with negativity for rheumatoid factor, weak positivity for rheumatoid factor, and strong positivity for rheumatoid factor. So again, the highest likelihood ratio is for double positivity of ACPA and rheumatoid factor. And this is based on the cutoffs of the manufacturer. We can do the same using cutoffs based on predefined specificity, the trend, the results are very comparable as what I explained you just before. And this is again the same for another commercial assay, very similar results, is very comparable across the results, and double positivity again has the highest likelihood ratio. So I conclude that again, defining thresholds for antibody levels and assigning test result interval specific likelihood ratios allows to align clinical interpretation of rheumatoid factor and ACPA assays. And we believe that serological weight factors for rheumatoid classification can be improved by taking into account the nature of the antibody. So we have seen that ACPA really has higher likelihood ratio than rheumatoid factor. And this is not considered now in the current classification criteria. And also, I think one should consider combined positivity, because combined positivity, again, has a higher likelihood ratio than single positivity. So I will finish, and I would like to thank all the people that have helped to realize the studies that I presented, as well as all the companies that also supported the studies. I thank you.
Thank you very much, Xavier, for this very comprehensive approach to the path to standardization of interpretation. I would ask here in the audience if someone wants to ask a question. Yes, we have one there, please.
Thank you for our talk. About the false positive results that we sometimes or many times with our patients, I think that some of them are real false, and so are healthy people. And another maybe they are preclinical phase of the diseases. You think that is a problem, or is only on my mind?
Yes, this is a very good question, and a very valid question. And of course, some people might have preclinical disease, and when we do the studies, we do not know that. However, I do believe that these real cases that are preclinical ones will only to a very minor extent affect the likelihood ratios that we calculate, because you could hypothesize that the individuals with a preclinical disease, the prevalence of these individuals will be lower than the prevalence of the individuals that we have with the disease. And if you take that into account and you do simulations, it will probably most likely not really significantly affect the calculations of likelihood ratio. And the other thing is, and I think this is one of the major advantages if you can assign likelihood ratios, is that the low positive ones are most probably those that are false positive. And by indicating the likelihood ratio, that's kind of information that you give to the clinician, and he can take that into account. Whereas if it is only positive, negative, this is kind of information that gets lost. But of course, your comment is very valid. But again, I think even though it is valid, I do not think that it really significantly affects the likelihood ratio. It does also affects if you only use a single cutoff point. There also you have the problem that you may have preclinical cases that have positive results. Yes.
If I'm allowed to add one one very small comment. It's very interesting to see that our clinical friends, when they look at lab reports, quite often they don't know what they have been writing on their notes. This is a way of us of saying someone is looking at the report, is taking his notes, and when asked by a colleague, what was the title or what was the result, the answer sometimes needs a recheck of the report. And this may be a consequence of the fact that usually these reports are used, as Xavier called attention to, as a yes or no option. People is willing to have an option of yes or no, positive or negative. And I think this is a bit of a sentence and a question for you, Xavier. I think that the likelihood ratio is a way of reminding people that many of these tests cannot, or at least should not, be used on a yes or no ratio. Please comment.
Yeah, I cannot do then agree with what you are saying. I think this is really the very important point that I think we should make. Yes, I fully agree.
So thank you very much. I must remind you that you must update your picture on the university because you are still with dark hair. And
that was the first day.
I've
yes.
known you always with your wonderful and very young white hair. But thank you very much for your splendid presentation. It's always a pleasure to hear from you. And we are already past our due time. So thank you very much and see you next time.
I wish all of you a good meeting further.
Now we are going to do a break, a coffee break, because Carlos Selmi is arriving from the airport, and we'll start after the coffee with him. Thank you.
Don't go away. We have Carlos Selmi, we have Jan Damozo and colleague, and then Kastner. So please don't go away.
ainda está o Carlos Vasconcelos, ainda não está. Vocês é que dizem. Good afternoon. We are a little late, so we'll begin the lecture of Professor Carlos Selmi. First of all, I want to thank Professor Vasconcelos and Dr. Carlos Dias, the invitation to be once again in PAMED Interna. The lecture is about recommendations of management of arthritis, psoriatic arthritis, ulnar versus grappa. Are there many differences? Are they important? And it's an honor to have here Carlos Selmi. Carlos Selmi is associate professor. It's known of all of us, but it's associate professor. He's a specialist in internal medicine and rheumatology by the University of Milan. He's head of the unit of clinical immunology and autoimmunity and metabolism laboratory by the University of Milan. Now he's head of clinical clinical immunology. He has multiple awards. In 2004, the Young Researcher Prize is co-author of 300 reviewed publications. It's always a pleasure to hear you, Professor. And
that was way too much, but thank you, my friend. Well, good afternoon, everybody. Thank you, Carlos. Thank you, Carlos. This is my first international trip since all of this started. So it means so much that it's to come to Porto, which, as you know, it's very, very close to my heart. So thank you for waiting. I know I'm late for my presentation, but Lufthansa lost a little bit of its touch with punctuality. So the goal today will be to discuss the two sets of recommendations that saw the light in the past few months, the Euler and the Grappa recommendations for the management of psoriatic arthritis. There's not only two recommendations, there's actually three, because only a few months earlier, the American College of Rheumatology and the National Psoriasis Foundation also came up with a set of recommendations, which I will not discuss today, because I think that the American recommendations are way far from the way we practice in Europe. So these are the ones I will be focusing on. And to do this, I will go through three issues. One is to take a look at psoriatic arthritis altogether. Two would be to see what the current recommendations say, namely, again, the Euler and then the Grappa recommendation. And then the last part, I will try to put them side by side to see what one tells you and what the other doesn't. So PSA, psoriatic arthritis is complicated. Psoriatic arthritis is like going uphill with a bike, like my friend Ian does all the time. You know, just keep going uphill. It takes a lot of effort compared to rheumatoid arthritis. Rheumatoid arthritis is like a walk in the park compared to psoriatic arthritis. Psoriatic arthritis has at least 6 domains you need to tick for each patient you see. And that is, of course, the nail and the skin psoriasis. And then there's 4 musculoskeletal manifestations. 1 is peripheral arthritis. 2 is enthesitis. 3 is dactylitis. And 4 is the axial manifestation. And that already creates an enormous number of combinations between these. And then on top of that, we don't really know how frequent these manifestations are. Because if you look at phase 3 trials for most drugs, you will see that 50, 60% of patients will have enthesitis, namely, especially of the lower limbs, Achilles enthesitis, plantar fasciitis, and so on. But then if you look at real life, these are data that come from the Corona Registry in the United States, will tell you that probably the real proportion of patients with enthesitis is only 20, 21%, which opens more and more questions. But if you think this is complicated enough, well, think again, because this is the core of psoriatic arthritis, the skin and the musculoskeletal manifestation. Around this, there's a lot of comorbidities, namely metabolic disturbances, the ones you see on the left-hand side, obesity, diabetes, non-alcoholic fatty liver disease. A third of patients with PSA will be obese with all the metabolic disturbances associated. Plus, and you see that on the right-hand side, all the associated conditions. These are immune-mediated conditions that are frequently associated with psoriatic arthritis. 2 are very relevant from a treatment point of view. That is inflammatory bowel disease, especially Crohn's, and 2 is acute anterior uveitis. And then, of course, there's depression and anxiety, and there's as well as the skin manifestation. So it's a lot of things. It's a lot of manifestations. It's a lot of things you need to focus on whenever you look and you see a patient with psoriatic arthritis. And that's why managing psoriatic arthritis goes through an early recognition of the disease, which is fairly complicated. Now, the average delay in PSA diagnosis is 7 years, which is unacceptable from many points of view. And then there's deciding what outcomes you want to measure, how you want to measure your patient. And again, if you have 6 domains you're looking at, it's not really that easy to pick one. And then decide exactly which pharmacological treatment is the best for that specific patient. So this is to say that psoriatic arthritis is probably the closest we can get to a personalized treatment approach in rheumatology. And that's why we need recommendations. We love recommendations. They do the work for us in many cases. We say, hey, I followed the recommendations, I'm fine. But we'll see that that's more complicated than this. Let's start from the EULAR. The EULAR recommendations came up literally a few months ago. They were created through an effort by 28 international members from 15 European countries. They met 2 years ago, which is already something that we should consider, because May 2019 seemed like a completely different era compared to today. They started with a systematic literature review between 2015 and 2018, and then analyzed everything, and then introduced something that is primarily evidence-based, but also opinion-based. And that's something we need to consider. Whenever evidence was insufficient to tell people what to do with a specific patient, then opinion would kick in. And the other important addition to the EULAR recommendation is that they also focus on the benefit to risk ratio in any choice. And that's why they're also focusing, for example, on biosimilars. So this is where it all started, the systematic literature review to identify which treatments were superior to the placebo on which domain led to this grid, which you see there. You see the arthritis as ACR 70, the physical function, the skin manifestation as PASI 75, enthesitis, dactylitis, and the radiographic damage, which is a very complicated issue in the case of PSA. And that's what we see. The good news is that most of this chart is green, which implies that most of these treatment categories are, or at least were, superior to placebo back in May 2019. And more of these boxes have become green since that time. So, you know, the recommendations start with overarching principles. These are very few sentences on which there's total agreement. Everyone agrees on this. Look at this. Psoriatic arthritis is heterogeneous and potentially severe disease. Who would not agree with that? Everyone would agree. But then the new thing about what happened in the update of these recommendations is that overarching principle E became available. So they came from 5, they went to 6 overarching principle. And that moves the EULA recommendations a little bit closer to the GRAPPA recommendations, as we will see. Because they say that each domain of psoriatic arthritis should be given full consideration when it comes to treatment choice. So you cannot only look at synovitis, which you're very good at looking at, you also need to look at enthesitis, at the skin manifestation, the nail, all together contributing and adding up to the quality of life of our patient. The EULA recommendations, like for rheumatoid arthritis, go through a nice flow chart. So it's very easy to work with. It starts with a diagnosis, and then it divides your patients into 4 categories. Namely, to the right-hand side, you have patients who have predominantly axial or enthesial disease, because they will skip conventional synthetic DMARDs entirely. There's no room for methotrexate in axial PSA. And then if you have a peripheral arthritis instead, you drift between mono or oligoarticular, in which intra-articular steroid injections can be used, or polyarticular, in which, depending on the manifestations and the presence of negative prognostic factors, namely elevated inflammatory indices, signs of radiographic damage in particular, then you will go ahead to start with a conventional synthetic DMARD. And then it comes treat to target. You evaluate the patient at 3 months. If it hasn't got any better, then you change your treatment. If it has gotten any better, then you go on until 6 months. And if by 6 months you have not achieved your goal, then you change your treatment. That's fairly easy. Once a conventional synthetic DMARD has failed, or it's contraindicated, such as in the case of enthesitis or predominantly axial disease, you move directly to a biologic. And in that case, all drugs are put on the same level. TNF-alpha blockers, IL-17 blockers, and with the exception of axial manifestations, IL-23 blockers. And they're put on the very same level, which tells us that the EULA recommendations will give us a lot of freedom on the choice of the drug in each of our patients. And then the new thing, the new kid in these recommendations is JAK inhibitors. JAK inhibitors start to be put in the picture of PSA. They say that can be used if inadequate response or intolerance, or when it's inappropriate, whatever inappropriate is, a biologic DMARD, then you can think of a JAK inhibitors. And then the new thing also is that when a patient is controlled is on a prolonged disease remission, then you can start tapering the treatment. As you can see, the EULA recommendations do not include dactylitis. And that's something that we don't really like, because dactylitis is a big deal in many patients. I know you can infiltrate, you can inject with glucocorticoids, but still many patients will continue to have dactylitis. So the EULA recommendations will basically put together dactylitis with enthesitis. And whether this is right or wrong would be up for discussion later. What about the GRAPPA recommendations? Well, the GRAPPA recommendations stem from this. These are the 2016 GRAPPA recommendations. And I think they fit better into the way we think of patients with PSA. Namely, we know that each patient has a dominant domain, be it skin psoriasis, be it nail psoriasis, be it enthesitis, dactylitis, axial, or peripheral arthritis. And so whenever you identify what the major need of that patient is, what the dominant domain is, that's the flow chart you should follow. And in this case, we are given a little less freedom. Let's be careful though, because the GRAPPA recommendations have not been published yet. So everything I will tell you today comes from an oral presentation that Laura Coates gave at the virtual Euler meeting in June. I basically took pictures of the slide and made my own slides. So what happened? If we, in 5 years, the domains move from 6 to 8. So there's still the skin, the nail, the entheses, the dactylitis, the peripheral synovitis, and the axial disease +2. One is comorbidities. We want to look at the patient also from a metabolic standpoint, because that influences a lot the infectious risk associated with any treatment we choose. And then the associated conditions. Associated conditions, again, namely include inflammatory bowel disease and acute anterior uveitis. And that led to specific recommendations, which are strongly in favor, conditionally in favor, strongly against, and conditionally against a specific treatment, which led us to some surprises. For example, if you look down here, no etanercept, for example, in the case of uveitis. Or, for example, we know that IL-17 should not be used in patients with overt IBD. And so we have 4 degrees here of recommendation, which translate into the updated grid, which will tell us very similar to what we've seen from the Euler. Let's take the synovial involvement. Synovial involvement, which you see at the back, at the far left, starts from NSAIDs, conventional synthetic DMARDs, then biologics, including apremilast as a small molecule, and then switch in case it doesn't respond. The axial disease will skip conventional synthetic DMARDs entirely and move from NSAIDs all the way to biologics, IL-17 and TNF-alpha inhibitors. Enthesitis, same thing, with some value for methotrexate, despite the fact that there's no dedicated study for that. Dactylitis, pretty much the same thing as enthesitis, and then the skin and nail psoriasis. And then again, in the case of uveitis, you may, all we have is the data about the monoclonal antibodies against TNF-alpha. We don't know about IL-17. We don't know about IL-23. We don't know, we really have not that convincing evidence in the case of etanercept. So we've seen the Euler, we've seen the GRAPPA. How do they compare? Well, let's start from the methods. The Euler is strongly rheumatology based. So they basically don't even look at the skin as a domain of the disease. The GRAPPA, on the other hand, includes virtually the same number of dermatologists and rheumatologists, which is something to me like an advantage. The method, we'll talk about that. The Euler, as we have seen, goes as a flow chart, so it's probably easier to follow in everyday practice. The GRAPPA recommendations go through domains, which I think fits better in the way we look at patients. The drug hierarchy is stronger in the case of the Euler recommendations compared to GRAPPA, and the extra-articular manifestations are better addressed in the GRAPPA recommendations. As you may have understood by now, there's different ways to look at the evidence as well and the recommendations. The Euler recommendations will follow the OCEBM method, which gives you also some recommendations based on opinion, whether those are expert opinions, whether those are international panel opinion, whether that's got a different degree of certainty. While the GRAPPA recommendations will follow the grade, which is supported by the WHO, and as we've seen, gives you a strong in favor, a strong against, and a conditional in favor, and a conditional against recommendation. What about the overarching principles? Well, not much difference there. Sincerely, we don't see that much difference, especially since I've told you earlier, what I've told you earlier, that is that the Euler recommendations start to move a little bit closer to the GRAPPA in discriminating between, for example, polyarticular and oligoarticular PSA, and including all the domains and treatment choices. When it comes to the skin, we've seen that in the GRAPPA recommendation, skin and other psoriasis have the dignity of their own domains, while in the case of Euler, it's a little square to say consider consulting a dermatologist in case of major skin involvement, which, by the way, is also considered to be a stronger indication for IL-23 or IL-17 blockers compared to TNF-alpha. Peripheral arthritis doesn't change much in the two. The Euler includes some predictors of poor prognosis of radiographic progression. There's GRAPPA, there's more flexibility in the route of administration, and there's a very different positioning of apremilast, the PDE4 inhibitor, which is the oral small molecule approved for psoriatic arthritis, with the GRAPPA putting it in a much better position compared to the Euler, in which the Euler will tell you that only whenever you have a mild oligoarticular PSA, and for some reason you think that a biologic treatment is not appropriate, then you should use apremilast. Axial, virtually the same. Again, no room for conventional synthetic DMARDs, which should be strongly indicated in patients where the axial disease is dominant. And then the proposed order, which includes only two types of molecules, IL-17 and TNF-alpha, are put on the same level. What about other domains? Again, not a big change here. There's a push for using an IL-23 or an IL-17 blocker in case there's a vast skin or nail involvement, because we know they have very, very good data for PASI 90 and PASI 100. Definitely want to prefer TNF inhibitors or IL-12, 23 inhibitors in patients who have IBD, particularly Crohn's, and favor monoclonal TNF inhibitors in patients with acute anterior uveitis. What about tapering? Both of these are very broad in the way of suggesting. You may consider tapering your treatment whenever you see a prolonged response to the ongoing treatment. There needs to be more data. There needs to be more dedicated studies to address and to give a final answer. So I'm done. What are my conclusions? My conclusions is that there's no winner. Pick one and stick with it. Just choose whichever feels closer to your heart, closer to your practice, closer to your reimbursement rules, and follow that with each patient you see in your practice. There's no reason to prefer one or the other. Okay? Honestly, I do think, but I have to say, I'm part of GRAPPA. So I am biased towards GRAPPA. I do think that GRAPPA has a better way to allocate patients the same way we do. Because the next patient that walks into our office, we say, hey, this is the guy with the bed to treat enthesitis. This is the guy with the axial manifestations. This is a guy with palmar and plantar psoriasis that doesn't respond to treatment. So we all know there's a dominating. And so don't hold your breath for a direct comparison, because no one would ever do a direct comparison for the efficacy of these. Again, pick one, stick with it, and you'll be absolutely fine. With this, I thank you very much. Obrigado, everybody. And these are the amazing people I have the privilege to work with in Milan. Thank you very much.
Thank you, Professor Carlos Selby. It's always a pleasure to hear you. I think the best is to call psoriatic disease and no psoriatic arthritis, because it's a complex disease and not only the articulation. Yes, anybody wants to make any question?
Thank you, Carol, for the very, very clear and excellent exposition. Tell me, a practical thing. I want to know, in your practice, if you have an idea of patients that are only on methotrexate, patients on TNF, and on other biologicals. Can you give us a?
Ooh, that's $1 million.
Yeah, I have.
It looks like you have the very same concerns we all have, and I truly appreciate that. So it's hard to draw a picture of patients, but let's say I think that methotrexate is very effective on patients who have peripheral arthritis. Few joints involved, joints in which intra-articular glucocorticoids don't really work, which they continue to use NSAIDs. That's where methotrexate, even generous doses of methotrexate, 20, 25 milligrams. Usually patients with PSA, in my experience, tolerate methotrexate better than rheumatoid arthritis, but that's my, again, opinion-based. Subcutaneous, yes. Definitely above 15 milligrams, you should use either intramuscular or subcutaneous, because there's one study that shows that this should be more bioavailable. TNF-alpha blockers are patients with a high burden of inflammation, axial disease, enthesitis, not a lot of skin involvement, and definitely either IBD or uveitis, okay? IL-17 has an even better, probably, safety profile compared to anti-TNFs. It works beautifully on the skin and on the nails. PASI 100. I wish rheumatology had ACR 100, but we don't. So PASI 100. So whenever you have a strong skin or nail involvement, IL-17 is fast, works really fast, works really nice also on the spine, on the axial manifestation. IL-23 is even safer from many points of view, is active on IBD. As we all know, it's very active on enthesitis. It's the only one that has a direct comparison about enthesitis in a small study against anti-TNF and came up on top with ustekinumab. So these are my views. And again, on the skin, IL-23 blockers are also marvelously effective on skin involvement. That's something, again, to be considered. Fortunately, most of us are under the impression that patients with psoriatic arthritis have only a less severe skin involvement compared to patients that the dermatologists will see.
Any question? I have one. In the past, the activity indices were separate. Now there are composite activity measures. What is the value of this new index?
That's a fabulous question, and it would take another hour to discuss this. I'll be quick. Yes, since there's a lot of domains, you would love to have one number or one yes or no way to evaluate your patients. So currently, there's two major ways to do this. One is very low disease activity and minimal disease activity. Seven ways, 7 yes or no. If you have all 7, it's very low disease activity. If you have 5, you have very low disease activity, and it includes the skin. So it's yes or no. There's no in between. There's no shades of gray. It's yes or no. That's fair enough, and includes the skin. The other one is DAPSA. DAPSA is a continuous variable, so will allow you to compare your patient from one time point to the other, but does not include the skin. Which one is perfect? Neither. Which one to choose? Choose whichever you want and stick with it. Same answer. Pick one, use it in your practice, whatever is most easy for you to use in your practice, and continue. Because of course, if you start with DAPSA and then you move to VLDA the next visit, you won't be able to compare your patient with the previous state. So pick one of these. Now there's the Grappa app on the smartphone that will allow you to punch in the data real quick and get a yes or no answer real quick. So it's very easy to do either DAPSA or very low disease activity. Pick one and stick with it.
Thank you. More questions? Thank you, Professor.
Good afternoon, everyone. First of all, I would like to thank Dr. Carlos Dias and Professor Vasconcelos for the opportunity to be here on this meeting. In this sunny day, Friday afternoon, beautiful city, thank you. In this next lecture, we will hear about myopathies. It is called the meringue. I don't know, maybe a dance, maybe a cake, sweet. Our speakers, Professor Jan de Moiseau and Professor Peter van Passen from Maastricht are well known to all of us for some years now. So any presentations will seem short on their massive curriculum, clinical practice, numerous papers. So that said, please welcome. Thank you very much, so much for being here, and it's an honor to have you.
Well, thank you very much for the invitation, dear Chairman. Kind words, and it's indeed great to be back in Porto. I was here, I think, 3 years ago, and then we couldn't make it for a year, and then COVID came, and it's good to be back. I like the city very much. And Jan asked me always, well, can you tell something about patients? And then he's the one who tells us about the lab. So we may be an example of how to collaborate. We collaborate for more than 20 years already and have our weekly meetings and discussing what we think are more complicated patients. And I would like to discuss with you two different cases in which we think the problem of the interpretation of lab values and new lab values are of importance. So the first one is, well, when rare diseases accompany each other. And this is a 73-year-old Caucasian male. He's a teacher and he's retired, and he felt quite well for a long time, apart from having a cardiac history, mitral valve insufficiency and coronary artery problems. But that has been solved in 2018. And apart from that, he was very active. He did smoke a lot before he was operated in the heart. And he then came to our clinic and he said, I'm very fatigued. We saw some fluid retention already, and I feel some weakness in my legs and even more in my arms. And we observed a skin lesion on the hands, and he was clearly mentioning decreased exercise capacity. So that was clinically very important to us. These are his hands, and what we can appreciate is that it really looks like Gotland signs, so that makes life maybe already quite easy, you would say, if you're an experienced rheumatologist or immunologist or internist. But I think we should continue and look whether there's something else also at stake. So this is clinical chemistry. And what we can see is that there's a not normal renal function, and there is a striking elevation in his creatine kinase, so showing something wrong in his muscles, and even the cardiac muscle seems to be involved as well. There is also some sign of inflammation with high sedimentation rate and high CRP. So clinically, there was a inflammatory myopathy, and you would ask for an immunological analysis. But before we did that, we also had a X-ray, and we saw some pleural effusion and signs of fluid retention with some consolidations. A normal X-ray is not the optimal way to judge this, so you would need a CT scan later, but this was just in his first admission to the clinic. And his ECG showed some depression in V5-6, but was not symptomatic at that stage. So we were wanting to have more cardiac imaging further on. But then we saw, well, the first question was, what are we going to have for the immunological analysis? What would you want? So the considerations from my side were, well, we always trust our laboratory. So if Jan says it's okay, then it's okay. The other question is, do we need a consultant of the neurologist? Do we need to have EMG? Do we need to have the biopsy? Do we need to have an MRI? Or can we go just straight forward to the lab and know what we want to find? We considered a dermatomyositis or one of the other antisynthetase syndromes. A role of statins was not that likely. Underlying malignancy was not improbable with his smoking. And what worried me was his organ involvement. So the heart and lung were at stake as well. We did, and we do know, and this is a study from the Netherlands, that if you want a biopsy, you would easily combine it with MRI, and then you have more accuracy. But if you have a biopsy, we also know you need to have a good biopsy, because if you don't, and this is an example of a good biopsy, and this is an example of not so good biopsy. This, my suggestion was give the word to Jan and help me with this case.
So yesterday we already had a presentation on myositis. So we have all these different antibodies that we can check for, and they also differentiate already in terms of the type of disease that you have. And basically about 3 years ago, I think we had a meeting from the ENMC, and there it was concluded that if you have antibodies in a patient with clinical manifestations of dermatomyositis, and you find a dermatomyositis associated antibody, then you do not need to take a muscle biopsy. Of course, we also have to stress from this picture that we talk about myositis, but some of these antibodies are also occurrent in patients that do not have myositis. So only interstitial lung disease whatsoever can have a relation with these antibodies, in particular with the antisynthetase syndrome. Now, most laboratories, as I will show you later on, use a multiplex assay for detecting these antibodies, but not all the antibodies in the picture above are available in this assay. Now, if you go to a clinical lab, the standard procedure is for systemic autoimmune rheumatic diseases that you start with ANA immunofluorescence, and based on a positive result, you can decide to continue with typing of the antigens that are potentially being recognized by the autoantibodies. Now we have two problems. First of all, with respect to ANA immunofluorescence, you often decide it's negative or positive. We heard Xavier telling about that the titer is also important, but also the pattern is important. And here we have to realize that you can see on the HEP2 cells, not only nuclear patterns, but you also can see cytoplasmic patterns. And the most important antibody is Jo1, of course, giving a cytoplasmic pattern. But in many countries, cytoplasmic patterns are reported as ANA negative. So there is no harmonization in that whatsoever. The second point is that if we continue subtyping of the antibodies based on antigen specificity, and we decide that Jo1, for instance, is a cytoplasmic antibody, so we report it as ANA negative, it's very strange that Jo1 is one of the autoantibodies included in the spectrum that we test if we find nuclear antibodies. So that doesn't make sense in a way. Nevertheless, many of the autoantibodies associated with myositis have a typical pattern in the ANA test. I will not go into detail with this. You can have a look at the website from ANA Patterns. There you can find clearly the associations, the clinical relevance of all these different patterns. But realize that some of these antibodies, for instance, MDA5, does not have any nuclear or cytoplasmic staining in the cells. The same holds for the HMGCR. So not all antibodies are associated with a pattern on the ANA tests. This is also reflected in a recent review from Xavier Bossuit. Here he mentioned several of these autoantibodies linked with the pattern that you can see on HEP2 cells, but for most of the antibodies, he's actually warning can be missed, can be missed, can be missed. So ANA testing is not very sensitive for finding these kind of antibodies. And that is also shown in this picture. If you look for a low titer screening with 1 in 40, which is extremely low, we saw that the 1 in 80 titer was associated with, for SLE at least, with a likelihood ratio of 0.17. But for myositis, 1/3 of the patients are being missed at this very low screening titer. So my conclusion is actually that if you are thinking about myositis, you should not start with ANA. You should start directly with the multiplex assays for myositis. Then you can ask the question, is there an option to confirm the finding that you have in your myositis test with an ANA test? So do it as a secondary test and see if the pattern fits with the antibody that you found. Now, there are several studies. This is one Italian study where they try to identify that. I'm not going into detail, but they look for different patterns for the different autoantibodies. And actually what they show is that in a patient cohort of 67 myositis patients, there was a corresponding ANA pattern in only 60% of the patients. In 40%, there was no corresponding pattern. It was somewhat different in the non-myositis patients, so there you have less chance of finding a fitting pattern, but nevertheless, although these data are significant, it clearly states that you cannot rely on the pattern in order to confirm the antigen specificity. So this question mark should be removed. The answer is no. And then the third thing that we have to realize is that if you think about systemic autoimmune rheumatic diseases, and it might be also an overlap syndrome, then you can start with a ANA test and the follow-up testing. But if you really think about a specific test of myositis, you better skip the ANA test and you directly go to the multiplex test. For the interpretation, I come back later. And this should also be allowed, of course, by the clinical laboratories. We talked about the communication between the clinicians and the laboratory, but this should be available for the clinicians even without a positive ANA test. So in conclusion from this part, in my opinion, there is no added value of the HEP2 immunofluorescence assay in the diagnostic workup of idiopathic inflammatory myositis. If there is suspicion of this type of diseases, you should directly go for the myositis-specific antibodies. If there is a suspicion of an overlap syndrome, you probably have to follow both routes, so the myositis-specific and associated antibodies together with the ANA immunofluorescence. And as mentioned, you can find here all the clinical relevance of the ANA patterns if you want to go in further detail for that. So coming back to the case, in this case, we did ANA testing and also the subtyping, and the ANA revealed a high titer of a homogeneous pattern and also a speckled pattern. We didn't find one of the classical ENAs, and if the myositis multiplex was done, we found antibodies against MI2. Some people say me too, but that's dangerous nowadays. And actually, MI2 fits with the speckled pattern that we saw, but as mentioned, that's not the most relevant thing. Also, additional things were measured in this patient, and on top, you can see that we also measure in many patients soluble IL-2 receptor and neopterin in order to see that there is activity of the T cell compartment, activation of macrophages by interferon gamma, etc., etc. They were highly elevated,
And we also saw that IgG was elevated, as we often see in systemic autoimmune diseases. In addition, we found a positive rheumatoid factor and type 2 cryoglobulinemia. And then, of course, it's for Peter to continue.
Got all these results back, and it was one part was less confusing, other was a little bit more, like the type 2 cryoglobulins. We always looked then for lymphoma, we couldn't find that, or hepatitis C, we couldn't find that. So we focused more on the MI2 autoantibodies and concluded that the patient had a dermatomyositis, and we still were worried about the clinical part of his dyspnea. So this fluid retention. So we did additional CT scanning and cardiac imaging. This is one of his slides, and what you can see is that there were some emphysematous lesions and there was some accentuation of septa, but it was not a clear ILD. And we also did a DTPA scanning. That's the scan that we use to find signs of alveolitis. If the DTPA clearance is fast, it is a sign that something is happening between the alveolus and the capillary wall that is adjacent to that. At least that's the interpretation of these data by us. But we did not find the clue in his lungs. That was the conclusion. Then we did cardiac imaging, and what you can appreciate is that, although it's not good to see in this cartoon, but his left ventricular function was normal, and that's the important thing. His right ventricular systolic pressure was elevated, and that is also signed by the TI regurgitation, and it was estimated being 65, which is quite high. So there was sign of pressure overload in the right ventricle. So what you need to do then is perform a right heart catheterization, and that's what we did. We used then the Swan-Ganz method, as all will know, and what we found was that his mean arterial pressure was indeed elevated. That was again proven, and importantly, the wedge pressure, which is a sign of his left filling pressure, was normal. His cardiac output was relatively normal, and the estimated pulmonary vascular resistance was elevated. And that all sums up to fitting the diagnosis of a pre-capillary pulmonary hypertension, which is a very important discrimination from a post-capillary pulmonary hypertension, which you can find in many pulmonary diseases. And the pre-capillary is what I consider to be the true pulmonary arterial hypertension, and it's also taken up by the last classification to include also the pulmonary vascular resistance. So that is a strange thing, and then you have to look to the etiology of this pulmonary arterial hypertension, and this cartoon on the left side indicates actually the classification, and this is the last from the last meeting. And what you can appreciate is there's no signs of left-sided heart failure, so that rules out class 2. There was no pulmonary pathology enough to explain it, so that rules out number 3. And we did perform a ventilation perfusion scanning and a CTA, and there was no sign of a pulmonary emboli, so that rules out number 4. Number 5, there was no metabolic disease. Malignancy we didn't really prove, but there was no, and also in the further story, no sign of malignancy. There was no congenital heart disease. There were no hematological disorders, no vasculitis. So then we have the idiopathic we're left with the idiopathic form because of the heritable is very unlikely. So what we ended up with that it is a PAH, a pre-capillary pulmonary hypertension associated with connective tissue disease. And we all know that the most well-known connective tissue disease is scleroderma and lupus. But for dermatomyositis, there are only some case reports, and it's not that well known. And what we then had to decide was how to treat the patient. And we decided, and that's a local habit, we are quite believers in plasma exchange in patients that have very severe a very rapid clinical deterioration, and we don't have the evidence from randomized trials, but we have, well, I would say a lot of experience in our own hospital for over the last 25 years. So we add plasma exchange in the beginning, and we gave him cyclophosphamide and a high dose of prednisolone with a fast tapering to treat the autoimmune disease, not only the dermatomyositis part, but also because we consider this pulmonary arterial hypertension related to this autoimmune disease. Apart from that, he got the PAH medication, he got the sildenafil and the endothelin receptor blocker. And for maintenance treatment, we gave him mycophenolate. The evaluation of the case is that his symptoms of myositis and inflammation resolved, and his right ventricle pressure normalized, which is quite impressive, I would say. And that has to be taken into account, that there was no fluid retention in a way like elevation of the left heart filling pressure to explain it, because then you can say, give him some diuretics and his pressure goes down. But this was actually the improvement from an initial situation without the left heart problem. And his 6-minute walking test improved after 1 year and did improve further on. So that brings me to the discussion from this in this first case, is to consider, is there a relation, and how will be the relation between pulmonary hypertension and dermatomyositis, or even taking it further into other quite similar, not similar, but diseases that look like that is, for instance, the antisynthetase syndrome. This is a cartoon from one of my PhD students. She just made it for this meeting here, and we are quite interested in Maastricht in immunological mechanisms of pulmonary arterial hypertension. I personally work together with cardiologists and pulmonologists already for many years in our outward patient PAH clinic. It's not a very large clinic, but we see all the patients from our region. And you can here appreciate the critical lesions that are found in pulmonary arterial hypertension. First of all, you will find changes in the smaller vessels. So the endothelial wall is involved, and there will be, your intimal layer will be much more pronounced. You also will have a mild hypertrophy of your medial vessel wall, and you will find neo-intima formation, and you will also find the classical plexiform lesions in these patients. And we and others, I mean, others are also very interested, I think, in the immunological mechanism of that. And I will not go into all the details, but the present situation is that there is either the thought that it is an inside-out system where it comes from the blood and the endothelial cell wall is attacked, and downstream the situation changes via fibroblasts and smooth muscle cells. But there's also a thought that it's outside in from the adventitia, an important role for macrophages. IL-6 is well known for the last 2 years as an important mediator of pulmonary arterial hypertension. Role of B cells and autoimmune antibody like anti-endothelial cell antibodies are all topic of research. And then we looked at our cohort of 140 patients over the last 10 years, and we differentiate in the total cohort. We differentiate between what we consider to be non-immune mediated patients and immune mediated patients, but the definition of immune mediated is rather relatively vague. We use the autoantibody as a key factor in that, because we want to learn from it, I would say. And if we look at this table, then we find that in our 76 immune-mediated patients, we find YO1 patients, we find PL7 patients, and we find TIF-gamma patients, and we find also other antibodies. But if we sum up together the patients that have antibodies within the spectrum of myositis antisynthetase syndrome, we collected 9 patients up till a couple of months ago. And these patients all have pre-capillary pulmonary arterial hypertension according to the strict diagnostic approach. So they all had right heart catheterization, they all had lung function tests, they all had exclusion of other factors explaining this important clinical picture. So we think these are all true pulmonary arterial hypertension patients. And the question for us as clinicians always, do we need these patients to be treated differently as compared to idiopathic pulmonary arterial hypertension patients? So that means, do we have to give them immune suppression on top of all the medication that is available for the elevated pressure? And that's important because these are, in my personal experience, very vulnerable patients. All of them, not all, but most of them will have oxygen. Most of them have a very impaired quality of life. So the decision to give them immune suppression is quite difficult. At least it's my personal experience. And then I will come back to Jan, because I was very happy with these results and we had these antibodies, and I started to say that I always trust the lab. And then I would like to ask you, Jan, because recently we saw 2 other patients in our clinic, a 53-year-old woman and a 70-year-old woman, also having a pre-capillary pulmonary hypertension, but they came back with quite amazing results, because in these cases, actually almost all the antibodies are positives. So there's where we got this discussion, and I said, well, Jan, what's wrong here?
Yes, and then I have a problem, because then I have to interpret the data, and there we really have a lack of knowledge, I have to admit. I'll try to show you. So first of all, in the laboratory, you have to choose the optimal test and the optimal algorithm for antibodies. And as already mentioned, the HEP2 cells is not the best way to start for these type of diseases. But we also have to deal with something else, and that's with all kind of management issues. So there will be a new law, European law, next year in May, and hopefully it will be delayed, but I'm not sure. And it says that you are not easily allowed to use LDTs. LDT means laboratory devised test. So if you devise something in the lab yourself and there isn't commercial assay available, which is acknowledged as an, according to this IVDR, you have to use the commercial test. Some commercial assays even go out of the market because of that, because the company cannot pay the money to get this registration. So we really have a challenge here. Now, keeping that in mind, if you look for studies, and that's why I asked a question yesterday about myositis, then the gold standard assays is immunoprecipitation for the myositis-associated antibodies. But immunoprecipitation is not a single technology. You can use different approaches, so making that a gold standard is difficult, but you get these kind of results. And now you have to tell me which band is what antibody. So I can tell you that in lane 2 and 3, it's SAE1. You have to believe me. In lane 4, it's PL7. In lane 5, it's PL12. But the only thing we know is that there is a band, a strong band, that has the same molecular weight as PL7 or PL12. It can be another antigen. So you never have the certainty that you have the right identification. So making this a gold standard is quite a challenge. Furthermore, it's a laboratory device test. These assays are only available in research laboratories. So I think in the Netherlands, nobody is doing this. I guess in Portugal, nobody is doing it. I know a lab in the United Kingdom. I know a couple of labs in Japan, but that's not the way to go. So then there are alternatives. And basically the only alternative that is readily available in the clinical laboratories is the multiplex immunoassays. That are the panels like this, where you do screening typing at the same time. So that are the line blots and the dot blots where you measure multiple antibodies at the same time. There are different assays available. I show here 2, but there are 2 or 3 more. And the problem is that if you use them side by side, you do not get the same results. So that's a challenge. So if Peter wants to rely on my results, I have a problem. Another thing here is that the antigens that are in the blood are not the same. So for instance, for MI2, you can see that on the upper part here, this blood uses MI2 alpha and MI2 beta, while this one only uses MI2. So what's the difference? How to interpret this? The conclusion probably is that they need to be positive both before you report this as a positive result, but there is no consensus on that. There are many other things we have to deal with, and one of them is accreditation of the lab. And for accreditation, you need to do a verification, which means that you have to ascertain yourself that for each antigen on this blood, the test is really doing what it should do. But patients with OG or EG antibodies are extremely rare. So you don't have the samples to do this verification. You also have to participate in external quality controls. But these external quality controls do not exist for all the antigens that are on the blood. So there we have a serious challenge. Now, in order to tackle this problem a little bit, we did a kind of verification nationwide in the Netherlands. So we took all the results that were obtained with the blood from Autoimmune that I showed you on top, and we looked whether those results were associated with patients with myositis or not myositis. And what I like to show you is that, of course, if you look in the myositis patients on top compared to the non-myositis on the bottom, the total positive number is much higher in the myositis cohort as compared to the non-myositis cohort. But still, in the non-myositis cohort, you have substantial amounts of positive results. Now, in these blots, you can distinguish between low positive and positive. And if you look for positive MSA, so myositis-specific antibodies, you can see that about half of the patients have clear positive results, while in the non-myositis patients, the clear positive results hardly ever occur. If you look for the weak positive myositis-specific antibodies, you can see them to the same extent in the myositis population as in the non-myositis population. So there, they do not differentiate. The colors that you see indicate the antibodies that there are. And the distinction between weak positive and positive may be different for the different entities. So that's another challenge. So for most antigens, we encounter that a positive result is rather reliable for myositis, and a low positive result is not that reliable, except for NXP2, which is an important antibody because it is associated with malignancy. There, you hardly ever find a clear positive result. It's always weak positive, and that is sufficient because you do hardly find that in the non-myositis cohort. So for each antigen, you may have to think about different cutoffs, which complicates it enormously. And then we come to the discussion how to report the results. I already mentioned that MI2 alpha beta you have to deal with, but we also have to deal with that it is recognized that some antibodies on these blots are not that very good. So if you take the OG, we know from expert opinions that, because there is not much evidence there, but from expert opinions, they say that the blots do not very well detect OG. So if you have a negative result, you don't know. If you have a positive result, it may be reliable, but the negative result does not exclude OG. Same holds for TIF1 gamma, and TIF1 gamma is a really important one because you have a very strong association in adults with malignancy. But on the blots, there is a thing both in terms of sensitivity, so you may miss it, but also in terms of specificity. And then again, we have a problem to be reliable in the results that we report. Now, if we talk about reporting, you can say, okay, it's positive or it's negative. You also get a kind of value with it. It's not standardized or whatsoever, but at least higher values, as mentioned and as also explained by Xavier, normally are clinically more relevant. So that's something that you could report. But as mentioned, we don't know exactly the values for the different entities. One of the options could be, of course, that we talk about likelihood ratios, and I'm not going to explain again the statistics behind it. I hope you learned a little bit from the story from Xavier about this. But if you work with likelihood ratios, you have a problem if you have a serious seronegative gap in your population. And about 1/3 of the myositis population does not have any antibody. And then you come into problems with likelihood ratios because sensitivities, cumulative sensitivities, are never covering this seronegative gap. And then, of course, also, if you want to calculate likelihood ratios for very rare antibodies, so some of these antibodies have within the myositis population occurrence of only 1%. And if at the same time you have a specificity for that antibody of 99%, which is quite good for an antibody assay, you have one false positive result and one true positive result. So you end up with a likelihood ratio of 1. And as Xavier explained, a likelihood ratio of 1, that's flipping a coin. It's less expensive, what I always say. So it's quite a challenge. But I think we need a multi-center study to determine for all these antibodies likelihood ratios and also in a cumulative way. And then the ideal situation would be, because I experienced that explaining the theory behind the likelihood ratios based on the ROC curves and all that kind of stuff is extremely complicated. What we should try to find is the third brain. We heard of 2 brains from Maria Jose, but the third brain is the computer, artificial intelligence. So what we should do is the clinician should give the input, the clinical manifestations of the patient. And based on that, the computer can calculate the pre-test probability for that particular disease. Then the laboratory specialist enters the results of the test and also the type of the test. And then the computer can calculate the likelihood ratio belonging to that specific result for that specific test. And the combination of the pre-test probability with the calculated likelihood ratio will result in the post-test probability. And that is the result that is reported to the clinician. And I think that is important, what you really want to know. It's not that important if the test is low positive, high positive, or negative, but if you change the chance on having a certain disease from 10% pre-test probability to 80 or 90% post-test probability. And then it would be really helpful. Of course, this is the future. So from this part, I like to conclude that, and giving answer to Peter, that it is very difficult to explain the data that we get from these assays, that results of different assays for myositis have a limited concordance. In general, low positive results are aspecific for myositis, but what we do not know if they may have a better value for PHA, for instance. Again, NXP2 is an exception because then low positive may be relevant. The myositis-specific antibodies are considered to be mutually exclusive. So if we go to those 2 patients, the more antibodies that you find, the less likely it is myositis. So if you find 7 antibodies, better go back to the clinic and see what's going on. As mentioned, results for some autoantibodies should be interpreted with care. For OG, it's in particular the sensitivity that is lacking. And as mentioned, we need a large multi-center study to really evaluate the value of these antibodies. And that not only holds for the specific, but also the myositis-associated antibodies. So in the end, there's a striking observation of the existence of true myositis-specific and associated antibodies and PHA. And for us, it indicates at least that there is an autoimmune process going on, having impact on the choice of treatment and prognosis.
And clear answers, and but I try to challenge you again because you said all the OJ that's well, if it's positive, it's maybe positive. And there was another patient that really, well, gave me a lot of worries, to be honest, because also he was also a because also he was a very young guy. He was 21 years old when I saw him first. He was sent to me, I believe, by the neurologist. It was a Caucasian boy from the region, and he felt that he got problems while playing football. I said, well, I'm not doing very well. There was no tobacco use. In his family, there was only some problem with the thyroid, and his brothers didn't have any medical problems whatsoever. His clinical symptoms that gradually developed were dominated by proximal muscle weakness, more in his legs than his arms. There was a little self-limiting dysphagia. He had a period of self-limiting alopecia. He said, well, my little dry mouth. He lost weight, which we considered might be related to his muscles. And he has some, well, nasal speech, whatever the meaning is of that. Then the general internist, that was before I saw him, had concluded that there was a problem with his thyroid. So there was a sign of a not working quite well. First of all, there was a thyroid working too fast. So there's a Graves, and the anti-TSH antibodies were fitting that model. And he then, at that point in time, had normal CK values with a very, well, he was very, was not a very heavy person. So there was the consideration that he had a Graves hyperthyroid problem, and they treated that. The neurologists did not find anything wrong while performing MRI. The biopsy didn't show clear picture of inflammation, and the performed CT scanning was showing little ground close capacities, but not that impressive. And his EMG showed low amplitudes, which could fit the diagnosis of a myopathy. The neurologist saw the guy, tested the reflexes, and said, well, it could be a myopathy, but it's strange. It could be related to the thyroid. It's not all that clear. So there were a lot of considerations then in that month of September. Maybe the antisynthetase syndrome with the pulmonary involvement. Inclusion was not that likely. Drug-induced was quite not likely. Necrotizing was not that likely. The thyroid, I already mentioned that. And genetic causes can always be considered in a young patient. At that point in time, because he was deteriorating, we did consider a antisynthetase syndrome, and we treated him again with immune suppression. And we often use in these cases, when you think it's very severe, the combination of calcineurin inhibitors with MMF in this case to lower the steroid use, because the steroids are not that very well for his muscles. The cotrimoxazole was just to prevent PAP. And a lot of his complaints resolved, but his muscle weakness was still disabling after rehabilitation. He was a very kind person, so he was never complaining, but you could see that he still was not in any way comparable to his peers. This is, and we were allowed to show it because it was in the newspaper in our region. It was an article, full article from where he was trying to, again, try to walk. And interestingly, there was not any immunological remark in the paper. It was all focusing on this apparatus where he could, this robot where he could learn to walk again. What I did not mention, although I miss it here, is that his immune results showed the OJ antibodies. I forgot to mention it clearly because, as Jan told us, OJ, when it's positive, it's important. And he had anti-OJ positive antibodies together with his thyroid problem. So that was the reason why we considered him to be having a antisynthetase syndrome and treat him. So far, relatively okay in a way that there was a problem with the biopsy. There was a problem with the MRI. So we had the antibody and trusted the antibody, but something was not feeling quite well from my part. And then he sort of disappeared. I saw him once in a while, and we called, and then we had the COVID episode where there was this situation that the patient didn't want to go to the hospital, and the hospital was also sort of restricted in seeing the patient themselves. And the family, his parents, and the young patient himself were very, I would say, shy people and not complaining. So there was a delay in my view. We did taper immune suppression also due to the COVID, and because of the fact that anti-OJ antibodies had disappeared, so he was on a low dosage of calcineurin inhibitor, no steroids, and his situation deteriorated. So he clearly got worse when I saw him back in summer of 2021. So this is this year. And then he complained of rapidly progressive muscle weakness, legs more than the arms, but also dyspnea. And it was a very, very impressive respiratory insufficiency and severe muscle atrophy, and then a reflexia. So there were no reflexes at that point. But he also complained of his eyes, and one of his eyes began to drop, and there was again weight loss. There was erectile dysfunction. So the clinical picture did change to a, what I would say, more myasthenic syndrome. So there was really a change from the first presentation to the presentation after the COVID episode. So we then considered, could it be myasthenia? We did perform I sort of summarized in this slide, summarized major data here. We did perform a exome sequencing looking for myopathy genetically and didn't find anything there. We did again, but that was actually, I would say, a useless operation. We did a new biopsy, but there was only atrophy with now more neurogenic degeneration. So also from the part of the neurologist, the clinical picture had changed. And now we did find in EMG non-excitable amplitudes, and repetitive stimulation was not anymore possible. So there was a neuron also, or the nerve was also involved. He was so bad that he got admitted to the hospital and straight to the intensive care because he was having a very severe respiratory acidosis and apneas, and he had to be intubated. And there we had a very severe situation where discussion with intensivists were, well, what is your diagnosis and what are the chances for this young man? And we decided to, again, give him the same treatment because we saw some effect in the earlier phase. So we did the plasma exchange again, and we were sending new samples to Jan. We did give him IVIG afterwards. We did give him CellCept, we gave him that back. And then we started to discuss about giving him complement blockade. And that has been, there's something to add to that. One of the reasons is that we, in our department, work a lot with complement blockade in TMA. And we do some research in that field. So we're quite interested in the concept of complement activity in disease. And there are some reports of myositis and C5a attachment in the muscles. And on the other hand, there is a relatively new study in refractory myasthenia showing efficacy in part of the patients with complement blockade. And we had a patient that was so ill, and the other problem was he also was on low calcineurin inhibitor. He had also already immune suppression. We did not have already find a positive antibody response against corona. So we were sort of mixed in between all different problems. And we decided to give him eculizumab because our experience with that is that it works very fast and the infection rate is very low and not a problem in COVID as far as we know. So Jan, my question to you is, you told me this guy has an OJ, this is a myositis, and what's happening?
Yes, I think the OJ was there. As I mentioned, there was also a second antibody, SRP, but that is with necrotizing myositis. So then you have normally sky-high CK values. He didn't have that. But as you mentioned, there was this issue, can it be myasthenia gravis in addition to myositis or whatsoever? That's something we have to check. The problem with myasthenia gravis is that you basically check for antibodies against acetylcholine receptor. Because what happens with in myasthenia gravis is that you interfere with the signal transduction from the nerve to the muscle. And of course, the signaling goes via acetylcholine, and that's picked up by the receptor. And if you have antibodies against this receptor, this function gets lost. This receptor is a complicated structure, and that's why you need complicated assays in terms of radioimmunoassays. And that's also the exact reason why it delays to perform these assays, that we didn't have the result directly available, because you need highly activated muscle tissue iodine of radioactive iodine labeled assays. So therefore there is some delay. Now, for the pathogenicity of these antibodies, you have to realize that anti-acetylcholine receptor antibodies occur in about 85% of the patients with myasthenia gravis. They may either bind to the receptor and then activate the complement system, because they are majorly IgG1 or IgG3 antibodies. And then, of course, you get destruction of the membrane where the receptor is localized. You may also have binding of the antibody to two receptors, and that's what we call antigenic modulation. And then the receptor is internalized in the cell, broken down. So then you also have a reduction of the amount of receptor. And the third mechanism that may occur is that antibody binds to the receptor and thereby prevents the binding of acetylcholine. So that's one part. The 15% of the patients that are negative for acetylcholine receptor, about 14% of these patients, 40% of these patients may have antibodies against another component, which is muscle-specific kinase. And muscle-specific kinase interacts with LRP4, and this complex together takes care that the acetylcholine receptors are linked to the cytoskeleton of the cell. And there you have thereby you acquire a stable expression of the acetylcholine receptor. So now you also have antibodies against MuSK, and in that case, you interfere with the complex formation with LRP4, and you do not have stable linkage of the acetylcholine receptor. So basically, you have the same clinical manifestations. Importantly, the MuSK antibodies have IgG4 type. So they do not have complement activation. They do not have antigenic modulation. So only blocking of the interaction with the LRP4. The patient appeared to be negative for both of these antibodies. So then we had a problem again. But then you have to realize that there is a third antibody that may occur, because not on the side of the muscle where you have MuSK and where you have acetylcholine receptor, but on the side of the nerve, you have these calcium channels. And you may also make antibodies against these voltage-gated calcium channels. And if you do that, you have the so-called Lambert-Eaton myasthenic syndrome, LEMS. And that antibody appeared to be present in this patient. And then I give it back to you, Peter, to solve this case.
The situation was, again, so thank you very much. Is that in the intensive care, we did not have these results. And if you work together with these colleagues, you know there's always pressure in the room, and you have to make the right decisions, but you don't have results back. So you say, well, it could be, but it is so rare that it's maybe not. And actually, we were quite happy that we treated him in that way, apart from one thing, is that we did not give from the start this amifampridine, because that's what you should give the patient as well. And that's what we gave him the moment we had the final diagnosis. He already did show improvement after the immune suppressive regime that we had given him. And he did make it, well, better than we had expected in the start, where he really did not have any breathing at all. I would very short say something about the Lambert-Eaton. We do know it, at least it was my first case of a Lambert-Eaton in a young patient. I know it from patients with malignancy, and being not a neurologist, so they do not primarily come into my office, but in this. So this is the first patient I encountered. And we know from the literature that the most part, 60% is tumor related, and the majority is the small cell lung carcinoma, and these are elderly men. And the interesting thing is that if you have a LEMS and a lung cancer, that your prognosis for your cancer is better. And in the non-tumor, there is a association with the HLA A1 and B8, and these are more younger patients in general and more female in general. We treated him, as I said, with this drug, and this drug works by blocking your potassium channel, and by blocking that channel, there is a indirect effect on the calcium vesicles that release more calcium than without this blocker, and that is important for the working of the acetylcholine, and so it improves your clinical situation, because actually these patients have a presynaptic problem. And the role of immune suppression is not well established in a way that there are no randomized trials. It's a rare disease. And there are some reports in literature about prednisolone and azathioprine. I think that the interesting goal would be to get the removal of the antibodies, because that's driving the disease, in fact. And that's the reason why we did give him rituximab. We know from anti-MuSK that that responds very well to rituximab, and the acetylcholine receptor antibody do not respond that well, and we don't know from the Lambert-Eaton. The eculizumab I explained to you is actually maybe it's a choice we made, and we stopped it after a while, and I think it had effect on the clinical situation as well, but it's hard to prove, and there's more research needed to find the role of complement activation in these patients. There's one small thing. This is just your workup for the Lambert-Eaton, but that's actually the usual workup for the suspicion of a malignancy. It's important to note, as I said, that prognosis of these patients that has been published is that if you have a non-tumor Lambert-Eaton syndrome, and this is a cohort of 65 patients compared to the Dutch population, is that they do actually relatively well while having immune suppression in combination with the drug I just mentioned. And if you have a tumor-related LEMS, your prognosis is much worse. And if you have a underlying disease, and I said that before, then your prognosis is a little bit better. In our case, we did October 15, so just a couple of weeks ago, we did a repeat EMG, and the situation had improved. We did not find HLA-A1, it was negative. We did not find positive genetic causes in the mitochondria, but we did not expect it after having the antibody back. And we are actually waiting for the pending whole exome sequencing, looking for whether or not he might have an underlying AIR or FOXP3 because of the fact that he has so many autoimmune phenomena in one young patient together. Having said that, the overall summary, and we tried by presenting to real-life patients the problems we encounter and the way we work together, the dance we have together, and it's nice to dance with Jan, as I try to make clear to you. The overall summary is that the antibodies, including the synthetases, are useful for the diagnosis, for subtyping, and the prognosis of the immune-mediated myositis, plus or minus all different kind of systemic manifestations, as I showed in the first patients. The MSA-associated precapillary pulmonary artery hypertension may be a novel clinical entity. We're working on the paper right now, and we're also working on a paper to see the difference between the patient that are treated with immune suppression having pulmonary artery hypertension on top of the usual medication as compared to patients that did not get this treatment, and results look quite interesting, I would say. The use of these assays has great impact, at least in my clinical practice. However, there is always this care for the right interpretation, and we always know that, have to consider alternative diagnosis. And the second patient, we did also check for his initial lab, and actually we found that his antibodies against the calcium channels were already present together with OJ. So we did miss the diagnosis, and that's not a good thing, because he was 21 years of age, and he was really, really almost not here anymore. But it went well. Thank you very much. And
Professor Damaso, Professor Hansen, thank you very much for these excellent presentations. Unfortunately, we are getting punishment, so there will be no time for questions. Thank you very much.
thank you. No problem, no problem.
Are you there? Yes. Aqui. Hello, Dante. Well, it's Carlos. It's only, I just pick up the microphone to say a few words. First of all, I really do apologize for the confusion about the time zone and so on. And I want to tell you that we are deeply grateful, thanks to you, and we admire your enormous kindness and humility. And in summary, you are our Nobel Prize candidate for sure. So now I give the micro to Raquel Faria. Thank you very much.
Hello, Dan. For those who dare not to commit the heresy of not knowing who is Dan Kastner, is a distinguished investigator in NIH in Bethesda. He works with systemic inflammatory diseases for more than 30 years. Since 1997, he's with the eSite, and he was on the groups that discover the genes for FMF and TRAPS, and so many since then. He was one of the main people that proposed the new autoinflammatory disorders concept. This year in February, he won the Crawford Prize of Polyarthritis due to describing so rare autoinflammatory diseases. And he added justice to the world of hematologist versus internal medicine rheumatology, because there is no dysplasia due to inflammation. The inflammation is due to dysplasia when they found what VEXAS was. And he's amazing, enthusiastic, and he sincerely had it hugely my eager to study these diseases. So thank you so much. The floor is yours in Porto.
Well, thank you so much. Can you all hear me okay? You can hear me? Okay. Well, thank you, Dr. Faria, for that really very, very kind introduction. And I want to thank the organizers for the opportunity to be here today. I wish that I could be there in person rather than doing this virtually, but we'll have to make do. And I am just delighted to have the chance to talk with you. So in any case, I have been asked to tell you about why autoimmunologists should be aware of autoinflammatory diseases. And I guess that the first thing that we should do is perhaps just to make sure that we're all on the same page with regard to what the autoinflammatory diseases are versus the autoimmune diseases. And of course, you know, at least at a basic level, there are two flavors of immunity: adaptive immunity and innate immunity. The adaptive immune system, as I think you all know, is the part of the immune system in which T cells and B cells are the major players. The receptors somatically rearrange and mutate, that is to say, the immunoglobulin genes and the T cell receptor genes. And autoimmune diseases are characterized by high titer autoantibodies and/or antigen-specific T cells. In the innate immune system, on the other hand, we have the situation in which myeloid lineage cells are the major effectors. So granulocytes and monocytes are major effector cells now, let's see, the slides are not advancing. It looks like behind. Can everyone see the slide that says two flavors of immunity?
Not yet.
Not yet? Let's see here. Share screen and here we go. Now can you see it? Now you can see it. Okay, my apologies. So anyway, we were just talking about the question of why an autoimmunologist should be aware of the autoinflammatory diseases. And I was saying, just to get everybody on the same page, that we should talk about the two parts of the immune system, namely the adaptive immune system and the innate immune system. So the adaptive immune system, as many of you know, has T cells and B cells as being the major players. The receptors, that is to say, immunoglobulin genes and T cell receptor genes, somatically rearrange and mutate. And the autoimmune diseases are characterized by high titer autoantibodies and/or antigen-specific T cells. On the other hand, the innate immune system is that part of the immune system which is much more ancient from a phylogenetic point of view, in which myeloid lineage cells are the major effectors. The receptors are hardwired in the germline genome, and the autoinflammatory diseases are characterized by seemingly unprovoked inflammation without the high titer autoantibodies or antigen-specific T cells that we would usually see in the classic autoimmune diseases. Now, of course, at this point, we know that this is a spectrum of disease, and that in fact, although there are certain diseases that we can really say are monogenic autoinflammatory diseases and more or less pure autoinflammatory, and others that are more on the pure autoimmune disease. Of course, there are various points on the spectrum in between the two. With regard to the answer to the question that is being posed to me by the organizers of this meeting, why should autoimmunologists be aware of the autoinflammatory diseases? I will give you 5 answers that we will talk about during the course of this presentation. First of all, they teach us about the biology of the innate immune system, and that's really important, and I'll give you some examples of that over the course of this talk. Secondly, they provide opportunities for targeted therapies that transform, at least the lives of the patients that have these diseases. Thirdly, they teach us valuable lessons about disease gene discovery, how we go after diseases. And certainly, Dr. Faria is exactly right that the Vexus story has really taught us a lot in terms of how to go after disease genes, and in particular, how to go after somatic mutations. And so we will spend some time on that. Fourth, they shed light on the genetic architecture of complex rheumatic diseases. And we will talk about a spectrum of disorders ranging from just common canker sores, sores in the mouth, aphthous ulcers that we all might get, ranging all the way to Behçet's disease. And then finally, they provide insights into the role of natural selection in shaping the immune system. And so really, there's a lot that we can learn from the autoinflammatory diseases. In any case, my first exposure, and this will just be a little bit of ancient history for you, for those who are not familiar with the autoinflammatory diseases, my first exposure to autoinflammatory disease before we called them autoinflammatory disease was back in 1985 when I was a beginning fellow at the NIH. And I happened to see a patient who presented to us with a history of recurrent fevers and episodes of monoarticular arthritis dating back to infancy. And he was of Armenian ancestry. And eventually we came to the conclusion that probably he had familial Mediterranean fever, although at that point, FMF was purely a clinical diagnosis. It was not a genetic diagnosis. And we really, although we knew that it ran in families and that it appeared to have a recessive pattern of inheritance, we didn't know what the gene for FMF was, or even what chromosome the gene was on, and certainly not the mechanism of the disease. And so this then, over time, became something that was a source of great fascination to me, because at that time, the Human Genome Project was just beginning to develop, and it seemed that it could offer wonderful opportunities using the new tools of human genetics to actually figure out what was the cause of FMF. And the hope was, of course, that it would teach us something about the immune system. We weren't thinking about the innate immune system at that point, but of course, it has taught us something profound about the innate immune system. So in any case, it took, from the time that I first saw that patient to the time that we found it, it was actually 12 years that it took to find the gene for FMF. I actually started working in earnest on that back in 1989, and it was 1997 when we found the gene, so 8 years of working in earnest on that. And in fact, towards the middle of the 1990s, another group, the French FMF Consortium, also started working on this, and we had quite a race down to the finish line. And so in the summer of 1997, fortunately, both we and our colleagues from France found the same gene on chromosome 16. So fortunately, we didn't have to have a dispute over what gene it actually was. That gene is labeled MEFV here. And it encodes a protein that was at that time actually a totally novel protein. It was something that hadn't been recognized before in any database. We called it pyrin after pyrexia for fever. Our French colleagues called it marinostrin, thinking about the Latin for the Mediterranean Sea. And of course, either name is okay. I think that pyrin, just because it's shorter and easier to remember, may be the name that we use a little bit more at this point. But in any case, this then became sort of the Rosetta Stone, if you will, to help us to understand a little bit about how the innate immune system works. And the first thing that we learned from pyrin was that it has this domain at its N-terminus that is sometimes called the pyrin domain. And that domain actually encodes a 90 amino acid motif that basically leads to the folding of 6 alpha helices in this part of the protein. And these 6 alpha helices allow for the production of a charge dipole. So you have positive charges in blue, negative charges in red, and basically you can have the interaction of the pyrin domain of one protein with the pyrin domain of another protein. In some cases, it's the same protein, the same kind of protein, a different molecule, obviously. In other cases, it's actually the pyrin domain of another protein. And just to illustrate for you what happens with this pyrin domain, I have a movie to show you, just for a couple of minutes anyway. This is a movie that I did not make. Instead, it's Kate Schrader that made it in Australia. And this is a movie about the inflammasome. And as many of you know, the inflammasome is a macromolecular complex that allows for the activation of interleukin-1. That's a very important part of the innate immune system. And the star of the show here is actually not pyrin, but another protein, NLRP3, which has a pyrin domain. So I'm going to start the movie going. And what you will see in a moment is that the star of the show will appear. And the star of the show is NLRP3. And here it is. And you can see NLRP3 has this red clown nose on the end of it, which is a pyrin domain. And right now, the NLRP3 is inactive, but there are certain bacterial toxins that will allow it to change conformation and become active. This then allows for the interaction of pyrin domains. And so what you'll see in a moment is that the pyrin domains of several of these NLRP3 molecules are coming together to form a disc, a wheel-shaped signaling hub, as it says here. And you can see they're all interacting via their pyrin domains. And now in a moment, we'll see it on its side, and it's coming in sort of like a spaceship, and you see the pyrin domains down at the bottom. Now what's going to happen is that we're going to get some molecules called ASC coming into the picture here. And they have a pyrin domain on one end. You can see the red pyrin domain, and then the brown domain, which is called a card domain. It has a similar structure to a pyrin domain, but card domains interact with other card domains. And you see it's forming a filament here coming down from the disk of the NLRP3 molecules. So in any case, we get this filament forming, and then we have these other molecules coming in. These are caspase-1 molecules. They have card domains also. And so they're interacting with the ASC molecules by like interactions, cognate interactions of the card domains, and that you get the assembly of these caspase-1 molecules, which then allow for the cleavage of IL-1 and IL-18. And now coming in is this other molecule, gasdermin D. Gasdermin D is one of the most toxic things known to man, woman, or child. And basically, caspase-1 can cleave gasdermin D and release the N-terminal fragment of gasdermin D. And we're going to see what happens with that in just a moment. So basically what's happened is that this inflammasome has assembled. It's brought in the caspase-1 molecules. They've cleaved IL-1 and IL-18 into their active forms, but IL-1 and IL-18 still can't get out of the cell until now we see the gasdermin D N-terminal fragments coming in, and they're about to form a circle here. And these circles actually insert themselves into the cell membrane, and you get a pore that destroys the osmotic gradient across the cell membrane. And lo and behold, the cell bursts. And that's what's going to happen. Yeah, and there it goes. It burst, and that's releasing the IL-1 and IL-18 active form into the intercellular space, and that then elicits the inflammatory reaction. So that's essentially the story of how pyrin and the pyrin domain have a role in regulating innate immunity. Now you may say, well, but we were talking about FMF, not about NLRP3. We'll get to that in a moment. And so then the question is, well, how does pyrin itself work? And pyrin itself can form an inflammasome also that can activate IL-1 and IL-18. The same thing as with NLRP3, but it's regulated by a different set of molecules. And pyrin is regulated by this molecule that sits on the inside of the cell membrane right here, that's called Rho A. And Rho A is a GTPase that ordinarily will activate certain kinases inside the cell that phosphorylate pyrin. And you see pyrin getting phosphorylated here by PKN, PKN1 and PKN2. And that then allows for these 14-3-3 molecules to bind to pyrin, and that blocks the pyrin inflammasome. If you have a bacterial toxin that inactivates RhoA, then you don't get phosphorylation of pyrin, you don't get binding of 14-3-3 to pyrin, and that allows for the activation of the pyrin inflammasome. So basically, the pyrin inflammasome is regulated by bacterial toxins that inactivate RhoA. And so it's a response, it's another innate immune response to various infections. And here I forgot to hit the animation buttons, but you see RhoA and then the PKN and the phosphorylation and the 14-3-3 binding. In any case, while all that was going on, we were seeing other patients at the NIH Clinical Center. And one of the patients whom we saw was a young woman named Christina, who was actually the wife of a employee of the Irish Embassy in Washington. And she had also a recurrent fever syndrome, which was seemingly very different from FMF. At the time we saw her, she was 27 years old. She had a 14-year history of febrile episodes that would last 3 to 5 weeks at a time. Now that's different from FMF, where the episodes last maybe on the order of 1 to 3 days at a time. So very long febrile episodes. She also had periorbital edema and a migratory rash with her febrile episodes, which you don't see in FMF. We saw her about a week after she had delivered a healthy baby boy, and she had been actually without episodes during her pregnancy. This is normal for the disease that she turned out to have. And as you can see, once she did deliver, then she had an episode, had elevated acute phase reactants, leukocytosis. She responded to corticosteroids, but not to colchicine, which again is not what you'd usually see in FMF. And here you see the pedigree where it looks like it's a dominant mode of inheritance. Again, not what we would see with FMF. So in any case, as it turned out, my former fellow, Mike McDermott, mapped the gene for this disease that she has, which was called at that time familial Hibernian fever, which Hibernian means Irish. And there were a few other Irish families that had this disease. And Mike was able to map the gene to chromosome 12 rather than chromosome 16. So we knew it was a different gene. And then he came to my lab and worked with Ivona Aksentievich in my lab. And together they found that the mutations were actually in the gene that encodes the P55 TNF receptor. So it was a totally different gene, totally different mechanism by which the recurrent fevers happened. And we published that actually in 1999, in early 1999. At that point, we had then seen 2 different genes that we had found that when mutated caused a recurrent fever syndrome without autoantibodies. And so we thought, well, maybe that's a new kind of disease. And so we thought, well, what will we call it? And we were working in a department that studied autoimmunity a lot. So we thought, well, to make ourselves different from the other guys, we'll call it autoinflammatory disease rather than autoimmune disease. So that's how we came up with that name, was just to set ourselves aside from the others. But we didn't know if there were going to be any other genes, any other diseases at all. About a year later, we published a paper in Current Opinion in Immunology, in which we thought about, well, what could be the other autoinflammatory diseases? I mean, we didn't know. We were making all of this up, just thinking about, well, what could it be if there were other diseases? And so one of the types of diseases that we said might be autoinflammatory were these familial urticarial syndromes, familial cold urticaria and Muckle-Wells syndrome. So we said we thought that those would be autoinflammatory. And then about a year later, Hal Hoffman published this article in Nature Genetics showing that in fact, the gene that is mutated in those two familial urticarial syndromes, Muckle-Wells and familial cold urticaria, that gene, in fact, has a pyrin domain. He discovered the gene and it has a pyrin domain. And we call that gene now NLRP3. That was the protein that we saw in that movie. And so that sort of showed that, at least for this way of thinking, that it does work out, at least in some cases, that some of these diseases where they have unexplained inflammation, but without autoantibodies, that maybe something else is going on and that there is a class of diseases there that maybe one could set aside. And the fact that the pyrin domain was at least one unifying factor was, of course, really neat. And then the other part of it was that by then it was becoming clear that, in fact, there was this connection between these molecules that had pyrin domains and could form inflammasomes and the production of IL-1. Now, the patients that have mutations in this gene, probably the worst phenotype is the phenotype that in the United States we call NOMID, neonatal onset multisystem inflammatory disease. And in Europe and most other parts of the world, it's called CINCA syndrome, for chronic infantile neurologic cutaneous and articular syndrome. Whether you call it NOMID or CINCA syndrome, it's a very bad disease. Kids are usually born with a hives-like skin rash. They have fevers from the first day of their lives. They develop aseptic meningitis, which oftentimes leads to blindness and deafness and intellectual disability. It's a terrible disease. And we had found that after Hal Hoffman had found mutations in that gene in Muckle-Wells and cold urticaria, that in fact mutations in that gene also cause NOMID. So we had a cohort of 18 patients at the NIH who had this disease where we didn't know how to treat them. And we knew that the prognosis for them was horrible. And we thought at that time, perhaps because of this connection with IL-1, that perhaps we could treat these patients with anakinra, the IL-1 receptor antagonist. And so here, this is a paper we published in the New England Journal in 2006 on this, and you see the patients before treatment, the hives-like skin rash, the conjunctivitis, the aseptic meningitis seen on MRI, inflammation of the cochlea, shown here pointed by the arrow. And then after just a couple of weeks, actually, on anakinra, and the fever goes away within a couple of days, and the rash goes away within a couple of days. But here you see the rash gone, the conjunctivitis gone. Within 3 months, the aseptic meningitis gone, and also the inflammation of the cochlea gone. And we have patients that we started in that trial back in 2003 or something like that, who are still on anakinra. And instead of the prognosis of being blind or deaf or in an institution or maybe not even alive, we have kids that started in that trial that now are in college. And one of them we saw recently who's majoring in biochemistry. So it's really just something that's a very, very gratifying thing and really makes you believe in, just the way all of these things fit together. So that's sort of my first couple of points with regard to why should an autoimmunologist know something about autoinflammatory diseases. Well, it teaches us something about the inflammasome and IL-1 activation, and also it's targetable, at least in some cases, and you can really make a difference in people's lives. We'll now move on to some other diseases that we have worked on over the years. Certainly one of the things that has been revolutionary in terms of the discovery of new autoinflammatory diseases has been the advances in next generation sequencing. And we heard about this in the last talk, that in fact, whole exome sequencing has become something that's readily available and commonplace. And that's because the cost of sequencing in about 2007, it started to go down much, much more rapidly than the cost of computing, as shown by Moore's law here. So in fact, with the increase in speed and the decrease in cost of sequencing, it became possible to solve a number of cases that we couldn't solve before. And that really has expanded a lot the spectrum of autoinflammatory diseases. I'll just show you one example that's a favorite of mine, and that is the story of a couple of little girls that we saw at the NIH over the course of several years. The first of them is a young girl who was 2 years old at the time that we first saw her, from New Jersey, who had had fevers for her whole life. We saw her in 2003, I think it was, fevers for her whole life. And at the age of 2, she had a catastrophic neurologic event. So she was sent to us with the question of, could she have NOMID, the disease that we just talked about? And in fact, she didn't have the hives-like skin rash. She didn't have mutations in the NLRP3 gene. She didn't have aseptic meningitis on the scans. And so we knew that it wasn't NOMID, but we didn't really know what she had. And we just treated her empirically for almost 10 years, not knowing what she had. And then we were referred another little girl from Texas. This little girl was 6 years old at the time that we first saw her. She also had a history of recurrent fevers dating back very early in life, and she had had 6 strokes over the course of her 6 years of life. And actually, the first patient had on MRI, we did see evidence of strokes. And so we had these 2 patients with recurrent fevers, unexplained strokes. We didn't know what was going on, and exome sequencing had become available. So we thought, well, what the heck? Maybe these 2 kids actually have the same thing. I mean, that was a dream, and it could easily have turned out otherwise, but we figured we'll do exome sequencing on the 2 little girls and their parents. So exome sequencing on 6 people, and then we would analyze the sequence and see if there was some gene in common between these 2 families. And lo and behold, there was one single gene that was in common between these 2 families. And at the time that we found this was back like in 2012 when we found it. We published it in 2014. When we found this, it was called CECR1 was the name of the gene. It's now called ADA2, which stands for adenosine deaminase type 2. I think many of you know adenosine deaminase type 1 is the enzyme that lives inside the cell and catalyzes the conversion of adenosine to inosine. Adenosine is toxic and its byproducts are toxic to lymphocytes. And so if you don't have adenosine deaminase type 1, then adenosine and its metabolites accumulates in cells. Lymphocytes are particularly sensitive to that, and you get severe combined immunodeficiency from mutations in ADA1. ADA2 is a different protein. It has some similarity to ADA1. It does, to a lesser extent, catalyze the conversion of adenosine to inosine, but it's actually an extracellular protein. And it has at least some role in terms of differentiation of subsets of myeloid cells, in individuals who have mutations in ADA2, there's a skewing of the macrophage population towards the more inflammatory M1 macrophage subset. So in any case, we published this in 2014. There was actually an Israeli group that was working on familial polyarteritis nodosa that also found mutations in this gene in families by exome sequencing. And so in any case, you can see here, these are the ischemic strokes that these kids can have in the deep brain nuclei. They have this livido rash, a livido racemosa, it's called, because the livido is associated with another condition. If you see a young child with this kind of livido rash, you should really think about this deficiency of ADA2. And then here's the ear of a patient that has polyarteritis nodosa and a gangrenous lesion of the ear associated with ADA2 mutations. This slide just depicts the fact that these patients have very low levels of ADA2 in the blood, circulating in the blood. And again, just like the case with NOMAD, in which we had children that had mutations in a gene that we knew caused a very serious problem for them and a bad prognosis. Same thing was true for these kids with ADA2 mutations. They were getting strokes on the order of once every 3 years. And so, we had a number of children with this disease, and we had nothing. There was nothing that we had available that seemed to stop the progression of the strokes. So in any case, one clue that we did have, one clue that we did have is that when we did some histology on skin biopsies, they had tumor necrosis factor, TNF, around the blood vessels. What's more, our colleagues in Israel that were taking care of the patients with polyarteritis nodosa with mutations in this gene, they had seen a patient that responded very well to infliximab, the TNF inhibitor. And so we thought, well, since we didn't have anything else to offer these patients, maybe if we put them on TNF inhibitors, we could prevent them from having more strokes. So here's a group of 15 children that we treated with TNF inhibitors. These are kids that have deficiency of ADA2, DADA2. And before going on TNF inhibitors, they had had 55 strokes over about 2,000 patient months of observation. In the study that we published in the New England Journal a couple of years ago, after going on TNF inhibitors, we had observed them for about 700 patient months at the time we published this, and the number of strokes was 0. So it's really remarkably effective. TNF inhibitors are remarkably effective in preventing strokes in these kids. Some patients with deficiency of ADA2 do develop a bone marrow failure syndrome, which cannot be treated with TNF inhibitors, has to be treated with bone marrow transplantation, hematopoietic stem cell transplantation. But in any case, again, something showing that if you find the right targeted therapy for some of these monogenic diseases anyway, you can have a huge impact on the lives of the patients and their families. So now we're going to turn to new adventures in terms of ways of finding disease genes. So for several years, for 5 or so years, we had been just happily looking at trios like I showed you before, using exome sequencing and trying to discover new disease genes. And we had been successful in a few cases anyway, and so that was really good. But then David Beck joined my lab. Now, David Beck is a genetics fellow, was a genetics fellow, and he saw that in our clinic, we have a clinic of autoinflammatory patients. There's about 3,000 patients enrolled in that clinic, and we have a molecular diagnosis on only about 1/3 of them. So in 2/3 of them, we don't have an answer. This was not good enough for David Beck. And so he was looking at what we were doing, and he was saying, well, I think you're doing things backwards, that we were doing things backwards. And so rather than doing what we usually do, which is to take a group of patients that have a certain phenotype, a certain clinical picture, group them together, and then try to do exome sequencing, as I showed you, in the case of ADA2, and try to find some gene in common amongst them. He wanted instead to start with a list of genes and then interrogate that list of genes against all of our patients, or as many of them as he could. So the list of genes that he came up with was a list of 841 genes that have something to do with ubiquitination. For those of you who don't know about ubiquitination, that is a post-translational modification of proteins that's very important in the immune system in terms of regulating the activity of certain immune related proteins. So, and we did know already, we had a couple of ubiquitination genes that when mutated cause various autoinflammatory diseases. So that was another reason that he thought to look at these ubiquitination genes. And he was going to then use that list of genes to interrogate 1,477 exomes from our clinic and 1,083 exomes from the undiagnosed diseases program. So about 2,500 exomes altogether, interrogated with 841 genes. And as his criteria for success, he was looking for genes that have a PLI of greater than 0.9. That means genes that are intolerant, very intolerant to variants. He was looking for variants that aren't present in the NOMAD database, and he was looking for variants that would be shared amongst cases. And out of these 2,500 or so exomes and 841 genes, he found 3 middle-aged men who are heterozygous for variants at position 41 of this gene UBA1. So in any case, on one account, you could say, well, that's great. He found something. And what's more, UBA1 is like the mother of all ubiquitination genes, because it actually starts the whole ubiquitination process. And so it was an important gene to find. But there was something wrong with this picture. And what was wrong with this picture is that these are men that he found were heterozygous for variants in this UBA1 gene. And the UBA1 gene is encoded on the X chromosome. So men only have, usually one X chromosome. So how could this be? So one possibility, of course, is that maybe it was a sequencing error. And in fact, some of the programs, computer algorithms that analyze exome data throw out cases of men who are heterozygous for X chromosome gene variants, because it's probably a sequencing error. At least that's the thought. So we checked to make sure it wasn't a sequencing error. It was not a sequencing error. So could these guys have an extra X chromosome? Could that be what's going on? So David checked for that, looking for aneuploidy. Nope, that wasn't the explanation either. So then what could it be? Well, the other possibility is that it could be somatic mutation, that it could be mosaicism, and that in fact, the mutation would only be present in a subset of cells in these men, and that the other cells in these men would have the wild type version of the protein. So instead of having all of the cells having 2 different versions of the protein, there'd be one subset of cells that would have the mutant and one subset of cells that would have the wild type, somatic mutation. So David looked for that. And lo and behold, on this slide, you see the evidence. So if you look on the left-hand side of the slide, in the peripheral blood, you see the wild type red peak shown there. This is where the mutation would be, and the mutant blue peak. So you have, this is basically what I was just telling you, that these men look like they're heterozygous for this variant in UBA1. They have both the wild type and the mutant peak in the blood. What's more, if you look in the bone marrow, they also have, it's superimposed, but there's a red and a blue right on top of one another. So again, they have those 2 peaks there. But then if you look in the peripheral blood, you see that in the myeloid cells, you see that you have a blue peak and not a red peak, or a very little red peak. So mutant form in the myeloid cells. But if you look in the lymphocytes, you see you have the red peak there, but not the blue peak. So the lymphocytes do not have the mutation. So that's exactly what I was saying would maybe be the case, is that one subset of cells has the mutation, namely the myeloid cells, and the other subset of cells doesn't have the mutation, namely the lymphocytes. You can look at this in a different way too, using something called digital droplet PCR. And one can see that fibroblasts from these patients, from the skin of these patients, don't have the mutation. The T cells and B cells don't have the mutation. But in fact, the myeloid cells, they have a very high percentage fraction of the mutation. So now I'm going to tell you about fact stranger than fiction. So we had heard, we had seen that these mutations are present in the bone marrow. And all 3 of our patients had had bone marrow examinations. And so we went to the hematopathology lab of the NIH and talked with the good doctor, Kathy Calvo. And so she was looking at the bone marrows of all 3 of these patients. And what you can see here is that in all 3 of the patients, in the precursor cells, you have these vacuoles. And she was commenting to us that this was quite peculiar. These vacuoles were quite peculiar, that she had seen it somewhere before, but she couldn't remember where. But it definitely seemed familiar to her in some way. So we went away and came back a few days later, and there she was, standing with 2 reports in her hand, which she very ceremoniously gave to me and said, "Here, Dan, here are the patients I was remembering. These were your patients from 8 years ago. They had these vacuoles too. You ought to go and check and see if they have mutations in UBA1 as well." So given that advice, she had thrown down the gauntlet to us. What could we do? We had to go back and sequence UBA1 in those 2 patients, and she was right that those 2 patients also had UBA1 mutations. One of those patients had relapsing polychondritis. And so that gave us the clue that maybe you could see these mutations, at least in some patients with relapsing polychondritis. Well, before you know it, we had 25 patients, all of them middle-aged men, all of them with unexplained fevers, all of them with these UBA1 mutations at position 41. And you can see what diagnoses these guys had. There were 15 of them that carried the diagnosis of relapsing polychondritis, but then there were others that carried the diagnosis of Sweet syndrome, myelodysplastic syndrome, myeloma, polyarteritis nodosa, giant cell arteritis. So a variety of things, and you can see it doesn't add up to 100%. It's more than 100% because some of the patients have more than one diagnosis, carried more than one diagnosis. But of course, they all had the same thing, UBA1 mutations. And so we decided this is a new disease. We are going to call it VEXAS. And VEXAS stands for vacuoles, E1 activating enzyme. That's what UBA1 does. That's what kind of ubiquitinase it is. It's X-linked, autoinflammatory somatic syndrome. Here are some of the clinical features that these patients have. In the upper left, you can see a scan showing the interstitial infiltrates that these patients can have. Here, you see medium vessel vasculitis of the bronchial arteries. Here, you see a neutrophilic infiltrate in the alveolus. Here, you see medium vessel vasculitis in the skin. Here, you see the chondritis in the ear. Here, you see the vacuoles. So all of these things going together. And if you look at under the microscope, electron microscope, if you look at the myeloid cells from these patients, remember I said that that's where the mutations are, is in the myeloid cells. You see a healthy neutrophil here, a VEXAS neutrophil that looks sick. It looks like it's going to fall apart or whatever. But they actually, these neutrophils do survive better in the bone marrow than wild type neutrophils do. And that's why you get a high fraction of the circulating neutrophils with this. And if you look by gene expression profiling, you can see that there's an inflammatory signature in the neutrophils and myeloid cells, but not in the lymphocytes. I'm not going to go through all the other details of VEXAS, but the big picture is using a genotype first strategy, one can define new illnesses based on genetic variants shared among patients that carry distinct clinical diagnoses. In other words, we're finding things in common amongst patients that carry the same clinical diagnosis. This may lead to a new molecular taxonomy of rheumatic disease. If we could go after disease genes in this way, we might find a number of these things that are in common amongst patients that right now we're saying that they have different diseases, but really they may have the same disease. Somatic variants for genes encoded on the X chromosome are probably under-recognized, as we saw in this case. And somatic mutation may account for a significant fraction of adult onset inflammatory disease. So I think these are important lessons to get. And these are lessons, again, that we're getting from the autoinflammatory disease. So by golly, you ought to know about autoinflammatory diseases. So in any case, we published this work on VEXAS in the New England Journal of Medicine in the New Year's Eve edition of the New England Journal of Medicine at the end of 2020. So in any case, within 3 months of the publication of that, it had made it to primetime TV. And so I'm going to show you just a little snippet from a TV show in the United States.
So in other words, we still don't know anything.
You might want to get infectious disease on this.
Thanks, Doc.
Ethan, if you don't mind, I've been giving your case some thought, and based on the symptoms that your patient's been exhibiting, I think he may have some rare autoinflammatory syndrome. It's called VEXAS.
VEXAS, never heard of that.
It's a genetic mutation. They've only diagnosed like 25 cases. Symptoms include blood clots, fevers, inflammation of the cartilage, and lung tissue.
It would certainly explain the crazy constellation of symptoms, but I'm still not looking for zebras yet.
You know what? I'm sorry for getting in your face over this.
Hey, Dean. You're right. Genetic sequencing found that mutation. It's VEXAS.
God damn.
I've already started treatment. Just amazing catch, man.
Thanks. Thank you.
Well, anyway, so it made it to TV, and actually VEXAS turns out to be a relatively common disease. We have looked in one large clinic population in the United States where it's seen amongst the exomes just of unselected patients in about 1 in 30,000 individuals. So in fact, VEXAS may be present in about 10,000 individuals in the United States. I know that in Europe, there are a number of centers that are now studying VEXAS. And so it is actually turning out to be something that you may actually see before too long. Well, I'm going to just move on to a couple of other short vignettes, and then we'll close things up. One has to do with finding susceptibility cassettes for endophenotypes in common diseases. So the common disease we'll start out with is Behçet's disease. And I think all of you know about Behçet's disease. Patients have the classic triad of painful oral ulcers, ocular inflammation, and sometimes genital ulcers. Some of them will also get pathergy phenomenon as well. And over the course of time, we, in collaboration with Ahmet Gül in Istanbul, have found a number of susceptibility loci for Behçet's disease using genome-wide association studies. Here, we're looking at, first of all, rare variants that are not common, but have a high effect that can cause a Behçet's-like syndrome. And there is actually one monogenic form of Behçet's that we found caused by mutations in TNF-AIP3, and it's called haploinsufficiency of A20. But there's a whole bunch of other genes that there are common variants of them that are associated with Behçet's disease. And in fact, by about 4 years ago or so, we had found 17 different genes besides HLA, variants of which can lead to Behçet's disease, increase your risk of Behçet's disease. So then what happened, this is really weird, is that I was at the American Society of Human Genetics meeting, and there was this guy from 23andMe, which is this direct-to-consumer DNA testing company. And they, in addition to looking at people's ancestry and stuff like that, they also have a questionnaire that they send to the people that send in DNA specimens. And they ask questions about things that they're interested in their research at 23andMe. And so someone at that time was interested in canker sores, just oral ulcers that we all might get every once in a while, canker sores. And so altogether, they had about 180,000 people that said, yes, they get frequent canker sores. It was just a yes or no question. Do you get frequent canker sores? 180,000 said yes. And about 66,000 said no. And they did a genome-wide association study. And lo and behold, they found a bunch of genes that gave genome-wide significance. And out of them, actually, 8 of them were the same genes that we had found with Behçet's disease, which was really kind of interesting because, with Behçet's disease, we had done thorough physical examinations, medical record review and so forth in order to make the diagnosis of Behçet's. And then we had found, the associated genes. Here, they are just asking people the question, yes or no, do you get frequent canker sores? But of course, they had a whole lot more patients than we did. And they came up with, at least to some extent, the same answers. So then enter into the picture Kalpanamanthram. who at that time was a fellow in my lab, and she was interested in the disease FAPA syndrome. So FAPA syndrome is periodic fevers with aphthous stomatitis, pharyngitis, and cervical adenitis. It is the most common periodic fever syndrome in children. It runs in families, but it's not a monogenic disease. And nobody had really found any replicatable genes that were associated with susceptibility to FAPA syndrome. But she figured, well, since in FAPA syndrome you get oral ulcers also, then why not look at these same genes that were associated with Behçet's disease and canker sores and see if maybe they're also associated with FAPA syndrome. And so she looked, and sure enough, at least for the ones where she had enough power in her cohort, which is 230 people, yes, they are associated. And so the genes that are associated, IL-12 alpha, that encodes the P35 subunit of interleukin 12, the subunits that's in common between IL-12 and IL-23. STAT4, IL-10, CCR1, CCR3. So you have this spectrum of disease with Behçet's on one end of the severity and recurrent aphthous ulcers on the other end, and FAPA in between. And if you look at HLA associations, well, you know, I think that Behçet's is associated with HLA B51 with a very good odds ratio. FAPA is associated with class 2 MHC molecules, also with a good odds ratio of 2. And then recurrent aphthous ulcers, it's a different class 2 molecule with a weaker odds ratio. So the stronger HLA associations associated with Behçet's disease, and maybe the HLA is telling us that microbial antigens have something to do with whether you get one or the other of these conditions. And this is the paper that Kalpana published back about a year ago describing these findings. And then finally, just to bring things full circle, thinking about autoinflammation as a Faustian bargain. So what do I mean by that? Well, what I mean by that is that perhaps some of the variants that we see in autoinflammatory genes are variants that increase our resistance to certain infections, but the price that the population pays is that there's at least some people then that develop autoinflammatory disease if they have, let's say, 2 copies of the mutation rather than just 1. So the way that we got interested in this was thinking about the question of why are the carrier frequencies for familial Mediterranean fever so high in Middle Eastern populations? And if you look at 4 different Middle Eastern populations, Turkish people, Armenians, Arabs, and non-Ashkenazi Jews, you see that the total carrier frequency for at least these 3 major FMF mutations is between 10 and 12%. Now, maybe you don't know how to put that into perspective, so I'll give you some examples of just to show how high that really is. So in the United States or in North America, the carrier frequency for cystic fibrosis, which is the most common lethal recessive disorder in North America, is 4%. Here I'm saying 10 to 12%. If you look at sickle cell anemia, if you look at the sickle trait in North America, the frequency of that is around 6 to 8%. Here we're doing 10 to 12%. It's pretty darn high. And it really does make you think that, well, maybe there was something selecting for that. But you can't just wave your hands and say, well, it looks like maybe that's what's going on. You have to do your population genetics. You've got to do your homework. So in any case, we did do that then. And you can see on this panel of this slide, we're comparing the size of the haplotype that's associated in blue with the mutant form, one of the mutations of the FMF gene, the M694V mutation, versus the size of the haplotype that's associated with the wild type version. And you can see that the mutant haplotype is much wider than the wild type haplotype. That's the kind of thing that you would see for something that's been under recent selection. But you have to go a step further and actually show then that that haplotype size is at the tail of the distribution of haplotype sizes for haplotypes of that frequency in the population. We're dealing with the Turkish population here. And you can see that, in fact, it is at the tail of the curve. So that is telling us that there was natural selection of some sort that led to the high frequency of the FMF mutations. So then you can also do, using these data, a calculation as to what's the selection coefficient of this particular mutation, M694V, in the Turkish population, and the selection coefficient is 0.077. Now, the selection coefficient for lactase persistence in the Northern European population, which is, in other words, the ability to digest cow's milk, that's something that has been looked at for a long time as being a good example of selection in a population. And the coefficient there, it's 0.056. So in fact, the selection for FMF is, in the Middle Eastern population, it's greater than the selection for being able to digest cow's milk in Northern Europeans. And then you can also estimate the age of FMF mutations using these kinds of approaches. And the age is somewhere around between 2,000 and 5,000 years. In other words, these mutations probably arose in biblical times. So then you may ask, well, what could have been doing the selecting? Well, remember I said that actually pyrin, the FMF protein, activates an inflammasome, and that inflammasome is basically triggered by bacterial toxins that inactivate this Rho-A molecule. So are there any bacteria that do that might have caused some big epidemics over time? And certainly Yersinia pestis was one that we thought about. And Yersinia pestis, which is the agent of bubonic plague. And Yersinia pestis makes two toxins, YAP-E and YAP-T, that in fact do inactivate Rho-A. So Yersinia pestis, plague, does activate the pyrin inflammasome by inactivating Rho-A. But plague also has another toxin called YAP-M. And YAP-M actually undoes the resistance of the pyrin inflammasome. So YAP-M actually leads to the direct phosphorylation of pyrin, and it blocks the pyrin inflammasome. So actually plague has a way of inactivating pyrin. But in people who have FMF mutations, it doesn't work. And so here on this slide, I show you the phosphorylation of pyrin in healthy control cells that have been incubated with Yersinia pestis. On the other hand, if the cells come from patients with FMF, you don't get the phosphorylation. You don't get the blockage of the pyrin inflammasome. What's more, if you look at IL-1 release, when stimulated by Yersinia pestis, in FMF patients, it's much higher than in controls. Even in carriers of FMF mutations, it's higher. But if you use a strain of Yersinia pestis that doesn't have YAP-M, the difference goes away. And if you take mice that have knock-ins for FMF mutations, FMF-associated human mutations, compared with knock-ins for wild-type human pyrin, you see that there's increased survival there. So one can actually then go back and say, well, so could this really explain the higher frequency of FMF mutations in the Turkish population? And so we did simulations in which we used the estimated age of the FMF mutations, the selection coefficient that I told you about, and also the history of plague in the Middle East. And in fact, the frequencies, the carrier frequencies that you get are very close to what we see in the modern day Turkish population. And if you want to read more about this, this is the article where we describe this. So just coming back to the original question, why should autoimmunologists be aware of autoinflammatory diseases? Well, first of all, they teach us about the biology of the innate immune system. I hope that you've learned a little bit from my talk today. They provide opportunities for targeted therapies that transform lives. They teach us valuable lessons about disease gene discovery, like Vexus. They shed light on the genetic architecture of complex rheumatic diseases, like the Behçet spectrum diseases. And they provide insights into the role of natural selection in shaping the immune system. So in any case, with that, I will call it to a close. These are the culprits who have been responsible for doing a lot of the work that I told you about. This is a meeting of patients with Dada-2 that we had in Bethesda several years ago. And certainly we owe an enormous amount to our patients for being there and willing to provide research samples for us to get to where we are today. And this is the clinical center of the NIH where a lot of this work is done. Here's my email address and the email address of my research nurse, to whom you could send referrals if you have any. So in any case, with that, I will call it to a close. I'm sorry if I went over, if I've overstayed my welcome, but hopefully you've gotten at least a little bit out of this. So at this point, I'll stop. And if you have any questions, I'm happy to try to answer them.
Thank you so much for your presentation. I'm going to ask if anyone has a burning question for Dan Kastner. I do have one question for you. I have a lot, but let's just do the one question. I heard you the first time talking about VEXAS on the press overture conference on the 24th September last year. Then on 27th January, we diagnosed our first VEXAS. And on March, I was watching Chicago Med and I heard that part of the Chicago Med series and I thought, what the hell? It was supposed to be rare and it's not. And what do you think about new discoveries of dysplasia and more somatic mosaicism? Probably autoinflammatory diseases, the bisomatic mosaicism, are going to be more frequent than the monogenic. What do you think about that?
I totally agree with you. I think that of the autoinflammatory diseases that our lab has worked on over the last 30 years, VEXAS is probably the most common one that we have found, you know, at least around the world. And certainly we are now gearing up to do other kinds of searches like this to try to find other similar kinds of things where there's somatic mutations. I would bet that, you know, if one takes cohorts of patients that have lupus, for example, you know, since we're talking about autoimmune disease, and lupus, you know, is really a very heterogeneous group of patients, that if one were to use a similar kind of strategy, that one might very well find subsets of lupus that have somatic mutations in various genes, besides just T-cell receptor and immunoglobulin genes, that they have, you know, somatic mutations in a number of different genes. So yes, I think you're right. And I think that this is really, you know, an exciting thing that others can work on over the course of the next few years. And I think we'll find a number of VEXAS-like conditions that are somatic mutations.
The last, you have a question? Okay, we have an audience question.
Peter van Paas, Netherlands. Thank you very much for this brilliant lecture. We also have some VEXAS patients thanks to your publication, and we found them in our ANCA negative vasculitis population. And the question to us is, how do we treat these patients? Because anti-IL-1, we saw some skin abnormalities, as you also mentioned in the paper, as I remember well. What would be the best way to treat these patients? Do they need transplantation if they're still in a good situation clinically? Or it seems that all the other compounds have only, let's say, relatively minute effects?
Yeah, that's a very, very important question. And right now we have set up a clinical protocol with one of the bone marrow transplant services at the NIH to do just that, to transplant the patients that at least are well enough to tolerate hematopoietic stem cell transplant. There certainly are a number of studies, you know, where people are trying various things, JAK inhibitors and various other agents, but so far I can't really say that there's strong evidence that any one of them is working. So right now it is transplant that is sort of at the center of our attention anyway.
thank you so much for having the kindness to talk to us, even after those misunderstandings about the time of your talk. And we are very pleased. I think all of us are late in the evening now, and we are really happy for having here you. Thank you so much for accepting this invitation.
Well, thank you for having me. I really, really appreciate it.
Bye, bye. Thank you.
Bye-bye.